Good morning and welcome. Thank you for joining us in the opening ceremony of the second Alauddin Health and Medical International Conference. With them, One Health Approach for Advancing Global Health, Friday, 17th of November 2023. Today, and the first agenda, presenting traditional dance performance, we call traditional dance Padupa. A traditional dance from South Sulawesi, it is a result of the copyright sense and intention of the Bugis Makassar, which is a symbol of respect, commonly called as a greeter dance. Ladies and gentlemen, here is the Padupa dance.
Tujui tontongan
Ladies and gentlemen, and all the participants, that was a four ethnic dance combination of four tribes of ethnics and culture in South Sulawesi, presenting by the student of Medical and Health Faculty of State Islamic University, Makassar. The next agenda, please stand up. Singing the national anthem, Indonesia Raya. The next agenda, Recitation the Holy Quran by Qori Muhammad Hidayat Esos.
السلام عليكم ورحمة الله وبركاته. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. ما آمنت قبلهم من قرية أهلكناها ما آمنت قبلهم من قرية أهلكناها أفهم يؤمنون. وما أرسلنا قبلك إلا رجالا نوحي إليهم فاسألوا أهل الذكر وما أرسلنا قبلك إلا رجالا نوحي إليهم فاسألوا أهل الذكر إن كنتم لا تعلمون. وما جعلناهم جسدا لا يأكلون الطعام وما كانوا خالدين. وما جعلناهم جسدا لا يأكلون الطعام وما كانوا خالدين. صدق الله العظيم. السلام عليكم ورحمة الله وبركاته.
At the next agenda, speech by the head of Indonesian Pharmacy Association of South Sulawesi, Mr. Andi Alfian, SSE, MSE, Apotheker.
ala Muhammad wa ala alihi wa sahbihi amma ba'd. Yang terhormat dan kita banggakan bersama Rektor Universitas Islam Negeri Alauddin Makassar, Bapak Profesor Hamdan Johanis, PhD, beserta jajaran rektorat yang kesempatan hadir. Yang kami hormati Dekan Fakultas Ilmu Kesehatan, Fakultas Kedokteran dan Ilmu Kesehatan Universitas Islam Negeri Alauddin Makassar, Ibu Dr. Dewi Setiawati, spesialis obstetri ginekologi, MKes beserta jajaran, para ketua program studi, para guru besar, para dosen dan tenaga kependidikan yang sempat hadir, yang kami hormati, para narasumber, presenter dan para peserta yang sama berbahagia. Pertama-tama marilah kita senantiasa memanjatkan puji syukur kehadirat Allah Subhanahu wa taala. Alhamdulillah berkat limpahan rahmat, hidayah dan inayahnya kita masih mendapatkan nikmat kesehatan, nikmat panjang umur, nikmat keamanan dan nikmat kekuatan, kesempatan untuk hadir bersama dalam rangkaian kegiatan pembukaan Second Alhamdik Universitas Islam Negeri Alauddin Makassar dilaksanakan oleh Fakultas Kedokteran dan Ilmu Kesehatan UIN Makassar. Bapak dan Ibu hadirin yang berbahagia, atas nama Ketua Pengurus Daerah Ikatan Apoteker Indonesia Sulawesi Selatan, saya menyampaikan terima kasih atas undangan kepada kami untuk ikut memberikan sambutan, dan saya menyampaikan selamat dan sukses atas terselenggaranya konferensi internasional Second Alhamdik ini. Semoga konferensi ini menjadi wadah untuk berbagi pengetahuan dengan harapan dapat menciptakan terobosan-terobosan baru, menjadi wadah pertukaran gagasan, pertukaran pemikiran, dan pertukaran pengalaman untuk memajukan bidang ilmu kesehatan dan ilmu kefarmasian yang kita cintai. Kita hidup di era di mana perkembangan teknologi dan informasi yang berkembang begitu cepat, dunia seolah menjadi lebih sempit dan tanpa batas lagi, namun persoalan-persoalan kesehatan masih banyak dan semakin kompleks. Pandemi yang baru saja berlalu telah mengajarkan kepada kita tentang pentingnya kerjasama dan kolaborasi sesama tenaga kesehatan dalam menghadapi kasus-kasus baru di dalam dunia kesehatan di masa yang akan datang. Dalam menghadapi tantangan dan semakin kompleksnya persoalan di bidang kesehatan dan kefarmasian, marilah kita bersama-sama melalui konferensi internasional ini untuk juga ikut menggali solusi-solusi yang inovatif untuk merespon dan menjawab persoalan-persoalan yang terjadi di masyarakat, serta kemungkinan tantangan-tantangan yang akan kita hadapi di masa yang akan datang. Beberapa masalah prioritas program nasional di bidang kesehatan untuk meningkatkan derajat kesehatan bangsa seharusnya juga menjadi perhatian dan kita dukung bersama-sama. Antara lain, masih tingginya angka kematian bayi dan ibu melahirkan, masih tingginya angka penularan kasus-kasus penyakit infeksi, tuberkulosis, dan HIV/AIDS, masih besarnya tantangan kita untuk penurunan stunting, semakin meningkatnya penyakit-penyakit degeneratif, hipertensi, dan diabetes mellitus, dan dengan program pemerintah melalui transformasi bidang kesehatan, 6 pilar yang dicanangkan oleh Kemenkes, diantaranya adalah kemudahan untuk layanan primer, akses untuk layanan rujukan di rumah sakit, kemandirian obat, DMHP, dan alat kesehatan, peningkatan kualitas sumber daya manusia, termasuk pembiayaan kesehatan, adalah program-program yang oleh kami sendiri di Ikatan Apoteker Indonesia terus kami dukung untuk bisa berkontribusi positif dalam upaya meningkatkan derajat kesehatan bangsa. Sebelum saya mengakhiri sambutan ini, perkenankan saya sekali lagi menyampaikan selamat dan sukses atas terselenggaranya kegiatan Second Alhamdulillah tahun 2023 ini, sehingga kemudian kita bisa berharap agar forum ini menjadi tempat berbagai pengetahuan dan hasil penelitian oleh berbagai pakar dari berbagai negara yang juga tentunya diharapkan menjadi hasanah pengembangan dan kemajuan ilmu pengetahuan dan teknologi, serta kita semua berharap pada akhirnya akan bermanfaat bagi kemanusiaan dan bagi masyarakat. Demikian sambutan singkat saya. Semoga konferensi ini berjalan lancar dan memberikan manfaat dan berkelanjutan bagi kita semua. Mohon maaf atas segala kekurangan dan kehilapan. Terima kasih. Hadanallah wa yakum. Assalamualaikum warahmatullahi wabarakatuh.
Thank you to Mr. Alfian. Ladies and gentlemen, the second Alauddin Health and Medical International Conference today aims to be a forum for socialization and exchange of ideas and experiences related to the One Health approach to advancing global health. And next, we would like to invite His Excellency, Rector of Alauddin State Islamic University Makassar, to present opening address and formally open the second Alauddin Health and Medical International Conference today. Please welcome Professor Haji Hamdan Johannes, MA, PhD.
Baik, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin, wassalatu wassalamu ala asyrafil anbiya'i wal mursalin sayyidina Muhammadin wa ala alihi wa sahbihi ajmain, amma ba'd. First of all, I'd like to congratulate having this international symposium. We call this Alhamdulillah. This is a routine annual conference, right? Yeah, held by the Faculty of Medicine and Public Health. And this is the second Alauddin Health and Medical International Conference. I remember last year I also came to the conference and opened officially our conference. I would like to give an appreciation to the organizers, especially the management of the Faculty of Medicine and Public Health, Ibu Dekan, the Dean, and all Vice Deans, and all the departments inside the faculty who work together to make this international conference come true. As a rector, I also would like to give an appreciation to all the speakers coming from across the countries to participate and contribute their ideas relating to the theme. And I see the theme of our conference is very interesting. One health approach for advancing global health. So one health approach, it can be maybe called as integrated approach from all the elements of medical personnels. They use their approach and methodology in the effort to advance what we call as global health. And as a rector, I am very happy for this conference because this is a combination online and offline, right? And this will support the development of our medical and public health studies in our university. I can mention all the speakers because there are numbers of speakers coming from different places. And I hope please enjoy the conference, take all the advanced ideas, the productive ideas to make our faculty and our studies can improve optimally. And especially for the presentation, I hope this can be published, not only end in this conference, but can be published and can be accessed by wider readers. I think that's all, and I'm really sorry I cannot stay long because I am already scheduled actually to attend another program, which was already scheduled since 2 months ago. Yeah, 2 months ago, and they have to reschedule their programs because of my position, stopping here to give moral support for holding this conference. Dr. Wahid Hadade, pembaca doa. Ya, ini pejabat kita. Ini salah satu pejabat yang setia membaca doa. Jadi beliau posisinya kadang naik turun. Jadi baca doa, kembali lagi jadi pejabat. Ini sebuah kontribusi yang sangat luar biasa. Thank you very much, and let's open this second international conference taking the theme One Health Approach for Advancing Global Health by reciting Basmalah. Bismillahirrahmanirrahim. Akhirul kalam. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you for Professor Haji Hamdad Johadis MA PhD as Director of Alauddin State Islamic University Makassar. Ladies and gentlemen, the second Alauddin Health and Medical International Conference organized by the Medical and the Health Science Faculty. This conference main objective is to socialize and increase knowledge about the One Health approach to promote the global health. And the next speech comes from the Dean of the Medical Health Science Faculty of State Islamic University Makassar. Please welcome Dr. Dewi Setiawati, SPOG, MKes.
Bismillahirrahmanirrahim. The most honorable director of UIN Alauddin Makassar, our honorable main guest from our faculty, Vice Dean Miss Isriani Ismail, Mr. Faiz Satria Negara, and Mrs. Fatima, our Dean last period, Mrs. Dr. Satira, our honorable chairperson of the professional organization from ID, IAI, PPNI, IB, dan Persakmi, our honorable distinguished speakers, and our respected fellows and all participants of the seminar, and also the committee of this seminar. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirrabbilalamin. Allahumma sholli ala Sayyidina Muhammad wa ala ali Sayyidina Muhammad. First of all, let us be grateful on the presence of Allah Subhanahu wa Ta'ala for His taufiq and hidayah, as well as relief and blessing to us, so we could gather here together for the second Alauddin Health and Medical International Conference, or second Alhamdik as abbreviation. Prayers as well as regards to our great Prophet Muhammad Sallallahu Alaihi Wasallam along with his family and friends. We would like to say thank you to all the audience who have attended in this online seminar, and also the committee. We hope you will experience a great satisfaction in learning during our 2 days conference. our best appreciation to all the colleagues and committee who have done lots of efforts in the implementation of this seminar and to make sure that everything goes well. Alhamdik, which is held by the Faculty of Medicine and Health Science of University Islam Negeri Alauddin, consistently for 2 years. Well, lecturers, practitioners, and students we have can gain information to ensure effective association with experts all around the world. Our conference today came up with a theme, One Health Approach for Advancing Global Health. We aim to socialize and exchange ideas, experience, achievement in advancing global health. In this seminar, we have so many participants from all over the world. I think there's from China, Egypt, Malaysia, Turkey, Australia, and also from Indonesia. We would like to extend our best regard to all our distinguished speakers like Professor Ying Jiang from Delegate of IDI Sulawesi Selatan, Dr. Abdul Aziz, and Dr. Syatira. Thank you, Doctor, from coming here. Mrs. Wahida Daud, and also they're from Turkey, Erman Gedikli from Istanbul, Sabri Zidan from Cairo, Professor Lisa McKenna from Australia, and from Mandala Waluya University, Dr. Wode Nova Novianti. We extend our sincere apologies to all the participants if there are any shortcomings in the implementation of this seminar. Allow me to end my speech with read pantun. Hari Jumat ikut seminar. Duduk di kursi dengan sabar. Mohon maaf atas segala kabar. Semoga semangatnya tetap berkibar. Tenang. Biru laut seperti kolam. Ikan paus pandai menyelam. Dari lubuk hati yang paling dalam, saya tutup sambutannya dengan salam. Assalamualaikum warahmatullahi wabarakatuh.
Thank you to Dr. Dewi Setiawati, SPOJ MKes, as the Dean of Medical and Health Science Faculty of Said Islamic University, Makassar. And the next agenda, recitation of prayer, will be delivered by Dr. Haji Abdul Wahid Haddad, LC, MHI.
Assalamualaikum warahmatullahi wabarakatuh. Let's take a moment to connect with our spiritual selves through prayer. Bismillahirrahmanirrahim. Nahmaduka ya man huwa mahmudun bi kulli lisan. Wa nashkuruka ya man a'ta ni'ami ala kulli insan. Wa nusalli wa nusallimu ala sayyidil insi wal jan Sayyidina Muhammadin wa ala alihi wa ashabihi ulil ilmi wal irfan. Allahumma ja'al jam'ana hadha jam'an marhuma wa tafarruqana min ba'dihi tafarruqan ma'suma wa la taj'al fina wa la minna wa la man hawlana syaqiyan wa la mahruma. Allahumma ya muhawwil al-hawli wal ahwal hawil ahwalana ila ahsani hal. Allahumma ya kathiran nawal wa ya khaliqa jami'il af'al waffiqna liniyatil khairi fil aqwali wal a'mal. Oh our Lord, inspire us that we should be thankful to your blessing. which you have blessed us and our parents, and that we might do good work that will please you. Admit us by your mercy among your righteous worshippers. Ya Allah, Ya Rahman, Ya Rahim. Bimbinglah kami untuk melawang orang-orang yang mengkhianati kami dengan kesetiaan. Membalas orang-orang yang mengabaikan kami dengan kebajikan. Memberi orang-orang yang bakhil kepada kami dengan pengorbanan. Menyambut orang-orang yang memusuhi kami dengan hubungan kasih sayang. Berterima kasih atas seluruh kebajikan dan menutup mata dari segala keburukan. Allahumma rzuqna hubbak wa hubba man yuhibbuk wa hubba kulli amalin yuqarribuna ila hubbik. Oh my God, grant us your love, the love of those who love you, and the love of every action that brings us closer to your love. Sallallahumma ala khairi halkika sayyidina Muhammad wa ala alihi wa sahbihi wa sallim. Walhamdulillahi rabbil alamin. Assalamualaikum warahmatullahi wabarakatuh.
Ladies and gentlemen, and all the participants, the opening ceremony is come to the end, and we will continue to the next session. First symposium of the second Alauddin Health and Medical International Conference today. These sessions, we have 4 speakers. Yingying Jiang, MPH, MSPH Professor, the National Center for Chronic and Non-Communicable Disease Control and Prevention from China Center for Disease Control and Prevention from China. And the second speaker, delegate of IGI South Sulawesi, Dr. Abdul Aziz SPU, Sub SP Oncology. And the third speaker from Dr. Shatira, SPA MCAS, Medical and Health Science Faculty, Alauddin Studies Islamic University Makassar. And the last speaker, Wahidah Daud, the supervisor from Hospital of University Science Malaysia. And also, this symposium will be led by our moderators, Ms. Nur Hidayah Sharifuddin, SKM MPH. Please come.
Hi, good morning, everyone. I'm Ying Jiang from China CDC. Thanks for the chairman and the host of the conference, and I'm so glad to participate in this international conference. So, shall I share the screen now? So I will share my screen, okay? Is that okay for the screen? Everybody can see it. Okay. Thanks for the chairman and the host again. Today I gonna present on a health promotion
Excuse me,
project.
Ying Ying.
Yes.
Oh yeah, this is I'm Nur Diana as a moderator for the plenary session today.
Is that
I'm
clear?
sorry. Hello, is it clear for my voice? Okay, thank you. Good morning, ladies and gentlemen. My name is Nudiana Sharifuddin. I'm the moderator for the first plenary session today, and it's my pleasure And it's my pleasure
Check.
test. It's my voice clear? Test. Okay, thank you. I'm sorry for the delay. Good morning, ladies and gentlemen. My name is Nurdiana Sarifuddin. I'm the moderator for the plenary session today, this morning, and it's my pleasure to welcome all of you in this the second Alauddin Health and Medical International Conference with the theme of One Health Approach for Advancing Global Health. One Health approach is a multidisciplinary and multi-sector approach designing to implementing and these programs, policy, legislation, and research, which requires collaborative works at the local, regional, national, and global level. As we learn from the global COVID-19 pandemic, then we can see that the global public health challenge will be more emerge in the future. And as is stated in the conference agenda, we're gonna have 5 speakers for this morning session, the first session, and the first speaker is Professor Ying Jiang, MPH, MSPH, PhD, and she is a senior researcher from the National Center for Chronic and Non-Communicable Disease Control and Prevention in CDC in China, and she got her PhD from the Griffith University, Australia. She is an expert on health promotion, comprehensive prevention, control, and evaluation of chronic diseases. So she will present the implementation and impact of China's National Comprehensive Non-Communicable Disease Prevention and Control Demonstration Area Project, or NDAP. Please welcome, I invite Professor Ying Jiang to present her presentation.
Thank you. Thank you for the host. I will share my screen.
Yes,
now.
please.
Okay. Thank you, Dia. Thanks for the invitation, and thanks for the chairman and host of the conference. Today, I gonna present on a health promotion project that conducted in China. The topic of my today's presentation is assessing the implementation and the impact of China's NDAP project. I come from China CDC. NDAP is a nationwide health promotion program conducted in China. And today I'm gonna share 5 aspects related to this health promotion project. First is the NCD issue and the challenges globally and also in China. And the other 4 aspects all related to the NDAP project in China. Of course, it is pretty clear that NCD are a big deal, whether we are talking about it worldwide or in China. From these pictures, we can see that every year, a total of 41 million people die from NCD. And there are 4 major NCD. They are cardiovascular disease, diabetes, cancers, and chronic respiratory disease. All these 4 major NCD contribute to 80% of all NCD deaths globally. And the World Bank has a prediction that in year 2030, 80% of all deaths will be attributed to NCD in high-income countries, Europe, Central Asian, and in East Asian and Pacific region, the number is also very high. It will be 85% in the coming 2030. And I can tell you that in China, in last year, this number is already reached to 89%. So Crohn's disease in China are spreading like a tsunami these years. From this figure, we can see the NCD, the burden of the NCDs in China. From here, we can see in year 1990, so the top five deaths are lower respiratory infections, neonatal disorders, stroke, COPD, and congenital birth defects. However, in year 2017, the top 4 leading cause of death in Chinese population are NCDs. So NCD in China is really a big issue these days. And apart from all these NCDs, the risk factors of NCDs are also very prevalent in the Chinese population. They all contribute to a significant number of related deaths in the Chinese population. From the recent article, we can see that the top 3 risk factors leading to the attributable deaths for Chinese people are dietary risk, high systolic blood pressure, and tobacco use. And China bears a heavy burden of Crohn's disease, and they are increasingly prevalent these days. Meanwhile, China is also facing the realities that we are living in an aging society, an urbanization society, and the significant material affluence the lifestyle of Chinese population. So to address all these challenges of NCDs, the measures or the strategies we should follow the principle of comprehensive prevention and control. During the health promotion project, we should take into account a variety of complex social determinants. They all associated with the occurrence and the development of chronic disease. That's why I'm focused on the health promotion project, and that's also why I want to share some information on this field today. So I will talk about some background of NDAP, which will make you guys have a better understanding of this project conducted in China. Actually, in China, the Crohn's disease control and prevention program started in 1969 in China, and the beginning of this project conducted, only single NCD has been addressed. For example, in 1969, in China, we have Shougang CVD project, and in 1980, we have Daqing diabetes intervention study, and from year 1982 to 1991, we have Henan Linxian cancer intervention study, and we also have stroke prevent and control program conducted in 7 cities in China. And in the earlier stage of all this program, they all address only one single CVD. And when the years come to 1997 to 2000, we got support from World Bank. This project is focused on the comprehensive control and prevention of all the NCDs. And this project, we call it a pilot study, is conducted in 24 sites and cities in China. And when the year comes to 2010, the NDAP project has been taken into action. And this project is aimed to cover all the 31 provinces in the mainland of China. That's the history of the NCD-related program conducted in China. For the NDAP, NDAP is a National Demonstration Area project. The aim of the NDAP program is to establish a batch of demonstration areas which will comprehensively control and prevent the major NCDs for the Chinese population. During the implementation of this program, there are 4 strategies we are focused on. First, the local government was required to guard the establishment of the demonstration area. Second, the multi-sector collaboration are highly recommended, and we combine the prevention and the treatment of NCD together, and we target both the individual risk factor of NCD and the social determinants of NCD. This figure is the scheme of NDAP administration. We can see there are 3 levels during the implementation of the NDAP project in China. The top level is the Ministry of Health. This NDAP project is officially launched by the Ministry of Health and with the technical support from our center, China CDC. And at the provincial level, the Department of Health in charge of the implementation of NDAP in their province. And at the district or county level, which is the 3rd level, or the bottom level, all the sectors such as the tourism department, education department, and all the sectors related to the health issues are encouraged to participate in. And of course, the district mayor or the leader of the county are in charge of the implementation of the project at their district or county level. That's the aim and the scheme of the NDAP project. There are 7 work domains of NDAP, which has development based on the health promotion strategy. From this table, we can see the 7 domains are policy formulation, build a supportive environment, and system integration, health education, and health promotion, management of the NCD from the screening to the treatment, and the monitoring and the evaluation. And the last is the innovation. This project has been conducted more than 10 years. And in the past 10 years, there are totally 488 districts or counties has established the NDAP. From this map, we can see all the 31 provinces in the mainland China has conducted NDAP program. And the NDAP has been proven to be a good platform where the local government lead the implementation of the comprehensive prevention and the control of NCDs. These pictures are the work photos during the implementation of NDAP. For example, this picture, the local governments are responsible for the convening health-related work meetings. They will in charge of formulating policies, guidelines, work plans, and the program for the health issues, especially for the chronic disease issues. And from here, we can see during the implementation of NDAP, there are many supportive environment has been set up. For example, the healthy park. This work has a collaboration with different sectors, such as the City Planning Bureau and the Education Bureau, and of course, our Health Bureau at the local level. And also the Department of Communication has their health education plan. They will invite the doctors, the public health practitioners to give health education on the social media and the mass media such as the TV, the radio, and the internet. And in the community, we have health communities where the public can get and learn the health-related skills. For example, how to eat healthy. Here we have the dietary pyramid, and we have some equipment. The local resident can use the equipment to do self-monitoring of their blood pressure, their weight, their with the circumstance. So they have a very good supportive environment. And also in the local community, we have patient self-management group. This kind of group is led by the GP at the community level. And the local residents can participate in this group to learn some skills of how to manage their chronic disease by themselves. And this slide shows the progress in the past 10 years in the implementation of NCD. We made an evaluation on the process outcome of the NDAP in China. We evaluate it from 5 domains. They are reach of the project, the effectiveness of the project, the adoption of the project, the implementation of the project, as well as the maintenance of the project. And we are happy to see the NDAP in China. It is the first healthy policies strategy implementing the community-based NCD strategy all over the 31 provinces in the mainland of China. And after more than 10 years of implementation, there are at least 3 achievements NDAP has made. First, during the implementation of NDAP, we built a supportive environment throughout the country. Second, we mobilized multiple departments such as health, education, sports, tourism, and the civil affairs departments to participate in the NCD prevention control work. Third, we developed a very complete NCD prevention and management chain from NCD and risk factor monitoring to cause of death registration to major chronic disease reporting, screening, and earlier diagnosis. From these slides, I display some numbers. From these numbers, we can see the achievement of NDAP. In year 2010, none mayor or the leader of the district or the counties undertook the leadership of the NCD program. However, by the year 2020, there are 13.5% of the mayors responsible for the NDAP work at their county level. That's a great achievement, which a house in all policies has become possible. And we can see the number of health units in each district have increased from 33 to 132, which means a very good supportive environment has been established for NCD control and prevention. And the patient self-management group, the coverage has increased from 31% to 60%. At 2020. That's all the significant progress made by the NDAP program. However, during the implementation of NDAP, we also observe different degrees of effectiveness in chronic control, disease control and prevention effort across from different demonstration areas. So we try to explore what are the contributing and what are the hindering factors to the implementation of the NDAP. In order to get the answers, we conduct some case study in several provinces in China. Here is the case study, the result of case study in 3 provinces in China. We consider in the geographic variation, so we select some provinces located in the north part in China, such as the Heilongjiang provinces. And we also select 2 provinces in the north part in China. They are Jiangsu provinces and Zhejiang provinces. And the findings are very useful. Today, I'm gonna show you what we have found, why some areas has good achievements and why some areas they have no progress in the past 10 years. So let's start from the enabler. Here is the enablers or the facilitating factors why some areas have the great achievement during the implementation of NDAP. First, they have the acknowledge the approach of health promotion. They know what is health promotion and the concept and the method of health promotion. They have comprehensive control and prevention of NCD, and also they integrated the local resources and project with NDAP. They have higher level incentives and assessment. Of course, multi-sector cooperation are highly applied in these areas where they have good achievements, and they input reasonable resources in the inner setting. They apply project management approach with assessment, monitoring, and timely feedback. I will also find some key persons. We call it the community championship. They play an important role in the implementation of the NDAP. Of course, they have. We've also found some barriers, or the hindering factors that make a not very good impact on the implementation of NDAP. For example, sectors other than health sector, they don't have enough knowledge about health promotion approach. And there's an inability to provide lifestyle tutorial services at the community health centers. For example, how to quit smoking, how to quit alcohol drinking, this kind of lifestyle intervention services, there's a lackage at the community health centers. And also, it's a common issue that in the primary health institute, the manpower is so limited. And in the past 3 years, because of the COVID-19 epidemic, it is prevent the task deliver of routine NCD services. It's a fact. So that's what we have found from the case study. Based on these findings, we think in the future, if we want to betterment the implementation of NDAP, we are highly suggested to provide appropriate training and user-friendly toolkits to enhance the understanding of what is health promotion and what's the concept of health promotion and how to design and evaluate a program with health promotion. That's all about training, and all these issues are very important if we try to make NDAP sustainable. Second, we encourage innovation and improving work efficiency through information technology, because the fact is there's a shortage of workplace, especially at the community level. So we try to encourage innovation, use some information technology. Maybe this is the best way to save the manpower at a community level. Also, a program should be tailored to local needs and conditions. That's our recommendations. And thanks. Thank you for your time to do this presentation. Thank you.
Thank you very much, Prof. Ying Jiang, Prof. Nina, for your great presentation. Before we continue for the next presenter, I'd like to let the audience participants to know that please save your questions until the end of the presentation from all our presenters, and then we'll continue with the discussion session. So the next presenter will be Dr. Abdul Aziz, specialist urology, subspecialist oncology, and is a representative from the Indonesian Medical Association, IDI Sulselbar, and he's going to present about the ethics and patient safety. Time is yours.
Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Ya, saya izin membawakan dalam bahasa Indonesia ya. Saya lihat hampir semua dari Indonesia. Bisa share screen ya?
Bisa.
Ya, terima kasih. Saya akan membawakan dalam singkat saja. Kita sekedar saling mengingatkan tentang etika profesi kedokteran yang ada di negara kita ya. Seorang filsuf kelahiran tahun 1778 ya, mengatakan bahwa tidak ada yang lebih pantas dihormati daripada seorang dokter yang telah mempelajari kebaikan sejak masa mudanya, yang mengetahui properti dari tubuh manusia, yang mengetahui penyakit yang menyerangnya serta obat yang bisa menyembuhkannya. Mereka memberikan keahlian dengan segenap jiwa raganya dan memberi perhatian yang sama pada yang kaya dan yang nestapa. Di sini kita melihat bahwa sejak zaman dahulu kala profesi kita orang medis itu sudah mendapatkan tempat di hati masyarakat ya. Jadi kita memang sudah dikenal sebagai sebuah profesi luhur, sebagai sebuah profesi yang mulia, bukan hanya seperti profesi yang biasa-biasa saja. Ya, disimpulkan oleh Voltaire sendiri bahwasanya seorang dokter adalah orang malang setiap hari tuntut untuk melakukan keajaiban. Ya, jadi ini menandakan bahwasanya kita sebagai orang medis memang senantiasa mengabdikan hidup kita, seluruh waktu kita untuk pasien-pasien kita, walaupun apapun yang menjadi tuntutan dari masyarakat di sekitar kita. Kondisi saat ini kita melihat secara sosio-kultural ya, tantangan kita, dinamika masyarakat yang sangat aktif ya di era sekarang ini, di mana meningkatnya juga pengetahuan dan kesadaran hukum masyarakat dan kehidupan individualistik. Hal ini menyebabkan banyaknya gugatan-gugatan kepada dokter-dokter ya, kepada orang-orang medis, bahkan sampai memicu kepada hal-hal yang namanya kekerasan dan ancaman kepada tenaga medis sendiri. Ditambah lagi sistem informasi ya, di mana seorang pasien itu bisa mengakses informasi apa saja, bahkan dengan adanya artificial intelligence yang ada sekarang ini, seorang pasien pun bisa memasukkan semua data-datanya dan bisa menegakkan diagnosis yang ada di situ. Nah, nanti kita lihat bahwasanya ilmu medis tidak terbatas pada hal-hal yang mengenai ilmu pasti saja. Dan juga adanya aplikasi dan medsos yang berseliweran di mana-mana, sehingga informasi begitu mudah didapatkan dan begitu mudah diakses oleh para pasien kita. Hal ini menuntut adanya peningkatan pengetahuan dan teknologi, dan juga berimbas pada meningkatnya pelayanan kesehatan dan pembiayaan kesehatan yang ada di tengah masyarakat kita. Ya, ini mempengaruhi cara berpikir dan perilaku kita para dokter, sehingga kita harus meningkatkan profesional conduct kita, yang yaitu meningkatkan pengetahuan dan keterampilan, dan juga performance kita, di mana kita harus senantiasa disiplin, senantiasa berlaku sesuai dengan standar prosedur yang ada. Dan juga ini menuntut adanya professional behavior dari kita para orang medis. Ya, di sini dituntut adanya integritas yang jauh lebih baik, kejujuran, berlaku baik dan menghormati hak manusia. Di mana kita sebagai seorang medis, di mana-mana, walaupun bukan di tempat kerja kita selalu dilihat sebagai sebuah profesi yang mulia, sebuah profesi yang luhur tanpa mengenal apakah kita berada di daerah pelayanan ataupun di tengah masyarakat umum. Sehingga profesi kita sangat melekat di dalam tubuh kita dan ini membuat kita harus mulai berperilaku yang lebih baik dibanding yang lainnya. Nah, pentingnya etika kita jaga adalah di mana ini menjadi guide bagi kita para dokter sehingga menghindari terjadinya penyimpangan profesi dan menjamin kompetensi dimanfaatkan sesuai pedoman moral. Nah, ini juga menjaga sumpah, disiplin, dan hukum kita, serta menjaga harkat dan martabat profesi kita. Kita ketahui bahwasanya akhir-akhir ini profesi tenaga medis, ya, profesi tenaga kesehatan yang ada di Indonesia begitu terpojokannya dengan adanya undang-undang baru yang berlaku saat ini. Sepertinya semua kesalahan-kesalahan, sepertinya semua kemunduran-kemunduran di bidang kesehatan di Indonesia itu disematkan berada di pundak kita. Walaupun kita ketahui bahwasanya ini adalah tanggung jawab kita bersama dan lebih besar lagi adalah tanggung jawab dari para pemangku kebijakan yang ada di daerah di Indonesia kita ini. Kenapa dikatakan dokter itu berprofesi mulia? Kita ketahui dokter juga merupakan suatu profesi seperti yang lainnya, merupakan suatu pekerjaan di mana kita bekerja dan bisa menghasilkan, di mana kita harus bisa dihargai sesuai dengan apa yang kita lakukan. Namun lebih jauh dari itu, kita adalah suatu profesi luhur di mana profesi kita ini senantiasa meniatkan, meneguhkan hati kita hanya untuk bertanggung jawab pada upaya kita untuk menolong manusia-manusia yang lainnya. Tidak pernah ada seorang tenaga kesehatan, seorang tenaga medis ketika bangun pagi, membuka matanya, pergi bekerja, meniatkan untuk mencelakakan orang lain ataupun mencelakakan pasien-pasien. Semuanya pasti berdoa bahwasanya semoga orang-orang, semoga pasien-pasien kita semua dalam keadaan baik-baik saja dan bisa sembuh sesuai dengan apa yang kita harapkan. Itulah yang membuat profesi kita menjadi suatu profesi luhur dan ini mengarahkan bahwasanya untuk mendapatkan itu maka kita harus menerapkan suatu standar moral yang tinggi disertai compassion yang baik dan juga penghormatan atas martabat manusia. Seperti kita ketahui dari sumpah dokter kita ini ya, ini kalau kita baca ya, ini sudah komplit dan sudah betul-betul menjadi guide kita sebagai seorang dokter, sebagai seorang tenaga kesehatan untuk berperilaku di tengah masyarakat, baik dalam pelayanan maupun di tengah-tengah masyarakat kita. Sumpah dokter ini mengandung konsekuensi bahwasanya kita harus menjunjung nilai-nilai ketuhanan dan kemanusiaan dalam menerapkan ilmu kita, menerapkan keterampilan kita, serta bagaimana kita berperilaku yang kita wujudkan dengan pengucapan sumpah dokter tersebut. Nah, nanti teman-teman sejawat sekalian bisa membaca kode etik kedokteran Indonesia. Di sini sudah lengkap sekali bagaimana kewajiban umum, bagaimana kewajiban kita kepada pasien, bagaimana kewajiban kita kepada sejawat maupun kepada diri kita sendiri. Nah, ini terkandung semua dalam 28 bentuk pelanggaran disiplin profesional dokter ya. Saya tidak akan membahas satu-satu karena keterbatasan waktu kita. Ini bisa dijadikan pedoman dalam melaksanakan pelayanan kesehatan di tengah-tengah masyarakat kita. Nah, apa akibat tindakan medik yang kita lakukan pada pelayanan masyarakat? Ada akibat positif dan ada akibat negatif. Yang disebut sebagai akibat positif yaitu di mana apabila tujuan yang diharapkan tercapai dan pasien pulang dalam keadaan sembuh dan lebih baik. Akibat negatif yang dimaksud adalah di mana tingkat penyakitnya yang sudah berat, di mana pasiennya terlambat datang berobat kepada kita, di mana adanya reaksi berlebihan pada tubuh manusia, misalnya shock anafilaktik yang kita kenal sebagai suatu resiko tindakan ya, bukan suatu kelalaian. Ya, jadi biasa terjadi di tengah masyarakat kita melakukan tindakan, kita melakukan pengobatan, ya ternyata ada reaksi tubuh pada pasien kita yang sebenarnya tidak pernah kita niatkan sama sekali. Bahkan kita sudah melakukan sesuai SOP dan itulah yang disebut sebagai resiko tindakan atau resiko pengobatan. Dan juga akibat negatif bisa saja terjadi apabila pasien tidak secara jujur memberikan keterangan pada saat anamnesa tentang penyakitnya dan juga ketidaktaatan pasien terhadap pengobatan-pengobatan yang kita lakukan. Semisalnya kita memberikan pengobatan tetapi pasien juga melakukan pengobatan lain di luar tanpa sepengetahuan kita. Nah, yang menjadi kesalahan akibat negatif yang merupakan kesalahan kita sebagai tenaga medis atau disebut sebagai kesengajaan itu adalah misalnya apabila kita melakukan sesuatu tanpa indikasi medis atau memberikan surat keterangan yang tidak benar atau surat keterangan palsu, dan juga ada yang disebut sebagai kelalaian, ya, yang disebut kriteria unsur yang meniadakan adanya kelalaian medik apabila kita sudah bertindak secara teliti dan hati-hati, kemudian sudah sesuai SOP atau ukuran ilmu medik dan juga kemampuan rata-rata dibanding kategori keahlian medik yang sama sudah kita miliki dan juga situasi dan kondisi yang sama. Kelalaian medis ini ya bisa berasal dari tugas kita di mana kita melakukan suatu tindakan medis ataupun tidak melakukan sesuatu yang seharusnya kita lakukan, ya. Kemudian apa yang sebenarnya dilakukan sesuai situasi dan kondisi yang disediakan. Kemudian marilah kita berperilaku sesuai dengan kompetensi kita, sesuai dengan standar dan SOP sehingga kita bisa menghindari yang namanya kelalaian medis. Dan juga yang disebut dereliction of duty, yaitu apabila kita menyimpang dari kewajiban-kewajiban yang harusnya kita lakukan, sehingga ini akan menimbulkan suatu damage atau kerugian-kerugian, baik itu kecacatan ataupun menyebabkan kematian yang dirasakan oleh pasien akibat layanan kesehatan yang kita berikan. Hal ini sangat berhubungan erat dengan unsur hubungan sebab akibat dari pelayanan kita yang kita berikan tersebut. Ya, jadi gugatan ganti rugi akibat suatu klaim medik harus membuktikan adanya keempat unsur di atas. Ya, dan apabila salah satunya saya tidak terbukti, maka kita tidak bisa dikatakan lalai dari tugas kita. Nah, apakah kita harus menolak teknologi atas nama etika atau menerimanya? Ya, seperti kita ketahui bahwasanya teknologi yang luar biasa saat ini, maaf, ya, teknologi yang ada saat ini betul-betul sudah luar biasa, bahkan sudah bisa menjadi dokter pribadi bagi siapapun dengan artificial intelligence. Namun satu hal yang tidak dimiliki oleh teknologi tersebut adalah bahwasanya seorang dokter, seorang tenaga kesehatan, seorang tenaga medis itu memiliki yang namanya etika profesi. Nah, ini yang tidak bisa dimiliki oleh mesin-mesin teknologi. Mereka tidak mempunyai empati, mereka tidak mempunyai simpati terhadap pasien-pasien dalam melakukan pelayanan kesehatan. Nah, akhirnya yang kita harapkan bahwasanya praktek kedokteran dijalankan dengan tetap menerapkan etika dan sumpah kedokteran yang telah kita lafazkan setiap saat, dan juga ini adalah long life learning dalam kita mempelajari dan menerapkan etika dan hukum kedokteran. Ya, terakhir kami katakan bahwasanya marilah kita bekerja sesuai indikasi dan SOP. Kita tuliskan apa yang kita lakukan dan lakukan apa yang kita tuliskan. Dan terakhir saya katakan bahwasanya hiduplah untuk jadi dokter atau tenaga kesehatan, bukan menjadi dokter untuk mencari kehidupan. Saya kira itu yang bisa saya sampaikan. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much for Dr. Abdul Aziz for the great presentation about ethics and professionalism in the medical, specifically for the doctors and medical professionals. All right. Thank you very much. And the next speaker is Dr. Shatira, SPA MCAS, and she is a senior lecturer and researcher from Alauddin State Islamic University, and also she is an expert on child health. She was the dean of medical and health sciences period of 2000 and 2003, 2019 to 2023. Her presentation will be toward a better health for our children, Indonesian experience. Please welcome Dr. Shatira.
Thank you. Thank you, Miss Nordiana. Is that my voice heard? Okay. Baik, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin. Assalatu ala asyrafil anbiya'i wal mursalin Sayyidina Muhammad wa ala alihi wa sahbihi ajma'in amma ba'd. Thank you for all the committee of Alhamdik, the second Alhamdik, because I was given an opportunity to speak in this seminar. Please, slide. Today, I will be talking about towards a better health for our children from Indonesian experience. I will talk about a little about what we have accomplished so far in Indonesian experience about our child health. Slide. The outline of today's presentation is about immunization program in Indonesia, neonatal screening program, and government policy, future hopes for a better tomorrow, and some take-home messages. We begin with immunization program in Indonesia. So actually, immunization in Indonesia has begun since in 1956 with the introduction of variola vaccine, and then followed by measles in 1963, and BCG in 1973, and DPT in 1976. So far, we have already 14 antigens in immunization program, in our routine immunization program. But everything changed after pandemic, COVID-19 pandemic. Globally, in 2019, nearly 14 million children missed out on life-saving vaccines, and 2/3 of them are concentrated in 10 middle and low-income countries like Angola, Brazil, Democratic Republic of Congo, Ethiopia, India, and Indonesia is one of them. Mexico, Nigeria, Pakistan, and Philippines. Slide. During the COVID-19 pandemic, parents refused to take their children to health facilities for immunization. We cannot blame them because since the policy during that time encouraged them to stay at home, wear masks, which is difficult for babies and children, and physical distancing and other policies concerning the pandemic, the children will lose the opportunity to receive scheduled immunization according to age, and this will eventually lead to decrease in immunization coverage. The coverage of each vaccine will be lower than the previous year. All this will cause extraordinary events and outbreaks of diseases which can be prevented by immunizations. And we will experience a significant setback in immunization after going a long way to reach this point. This is the map. So we have an outbreak distribution of polio vaccine-derived poliovirus type 2 in 2022 and 2023. There are one cases of polio vaccine in 2022 was found in PD Regency Aceh, and then 2 more cases in North Aceh and Buren Regency, and then it spread to Purwakarta Regency. The next one is slide. The next one is the outbreak distribution of diphtheria from January to April 2020. There were 3 reported, 21 confirmed measles outbreaks in this district. So in 2023, there are many cases of diphtheria cases we found in Indonesia, and this is not really good actually. And in 2023, from January to April, we have 55 outbreaks of pertussis and we in 55 districts and cities in 19 provinces. The frequency of pertussis from weeks 1 to 17 in 2023 has increased ninefold compared to the same period in 2022. And this is the outbreak of measles. We have if we compare the cases of measles in week 1 until 17 in 2023, there is an increase 1.5 times compared to the same period in 2022. So I guess this is the cause of pandemic to the disease caused by vaccine. The disease that can be prevented by vaccine. Then but is it our government stay still? No. We got the government has done a lot of things to prevent this, and that is by introducing new vaccine, new antigen in our immunization program. Since beginning in 2016 until 2021, we began to introduce PCV, pneumococcal conjugate vaccine, in some area, but only in some small space of area, not nationally. And then HPV, human papillomavirus, in some in DKI Jakarta, and then we haven't introduced rotavirus and IPV2 yet. We began to introduce Japanese encephalitis in 2018, and specifically in Bali because that place is a little bit endemic with Japanese encephalitis. We began to introduce PCV, HPV, RV, and IPV2 in 2023, this year. And Alhamdulillah, maybe not all children got it because some of them are kind of out of stock. But actually, these vaccines are already distributed nationally. That's for General Directorate of Disease Prevention and Control in Indonesian Ministry of Health stated that 1.9 million babies have not received complete basic immunization during 2019 and 2021. And this is a huge number. This is a huge number. The catch-up immunization was performed under the guidance of WHO and the Indonesian Ministry of Health. The general principle concerning the type of vaccine, which is the recipient's age, the immune status, the vaccine interval, and grace period, were carefully made according to the evidence-based medicine. The Health Ministry also encourages immunization program among school-age children for elimination and Indonesian free from polio program. So the catch-up immunization is also done through backlog fighting to complete immunization according to age by doing dropout follow-ups and boosters. So we hope by doing this, we can have high coverage and achieve herd immunity. This is what we call sweeping. Sweeping is an active effort by primary healthcare providers doing house-to-house visits. So this program aims to search for babies and toddlers who have not received any immunization yet. These babies and toddlers who are not recorded in the cohort book or immunization registry at the Community Health Center or Posyandu, including those who receive immunization services at private health service facilities. By doing this, we hope, and I know we can increase immunization coverage and improve our big data. This activity is carried out at least every 3 months. So before administering a vaccine, we also have to educate the parents or the caregivers because we need to verify that all previous doses were administered after the minimum age and in accordance with minimum intervals. To reach the missing vaccination, we ask the parents to receive the combined vaccine for their children or multiple injection to simplify the schedule. And that's what we are doing now. We are doing multiple injections. Some may refuse, some may accept it, but we have to make this through. So educating the parents, not yet. Educating the parents or the caregivers can be done by doctors, nurses, midwives, and medical and health students, particularly in community health centers. Nowadays, online seminar becomes standard and social media can be used as a health promotion event. slide. So right now, this is the national immunization schedule for children below 2 years of age in Indonesia. So as you can see, you used to be only have one injection, one times dropping from the mouth, but now we can make in the second month and 3 month and 3 month of age, the child will receive 2 vaccines, injection vaccines, and 2 drops in their oral vaccine. So we are going better. I think we're going better. So it's an improvement. Right. And this is the vaccine immunization for school-based programs. So those kids, grade 1, 2, and 5, and 6, aka those in elementary school, grade 1, they will receive DT and measles, rubella vaccine. And then when they get to the second grade, they will receive tetanus diphthery vaccine. And then when they are in grades 5 and 6, they will receive an additional of human papillomavirus 1 and 2. So it's a better thing right now. Right? So these are what we have been as mandated by Health Law number 36 of 2009, which states that every child has the right to receive immunization following the law to prevent the occurrence of diseases that can be avoided through immunization. We hope this effort will receive broad support from the entire community, especially parents, to provide their children with complete routine immunization according to the law. So in this way, immunization coverage can increase and become more evenly distributed so that the goal of vaccination, namely the formation of individual immunity, group immunity, and cross-group immunity or herd immunity, can be achieved. That's the first part of our session, and we continue with neonatal screening program. So when I was born, I never screened for any screening. I never got any screening. My children got no screening at all. But we know that there is a disease that can cause a very bad damage and long-term irreversible effect for the children. So this is the background. Why? Because infant mortality rate in Indonesia is in 2020 is about 16.85 per 1,000 live birth. It's still not gaining the target of a National Medium-Term Development Plan atau RPJMN target in 16. And SDG's target in 2030 is 12. So we're still kind of a long way from there, but we're working on it. And neonatal mortality rate in Indonesia in 2020, 9.3. So we're kind of good there. And we are going to receive, so it is predicted that Indonesia will get a demographic bonus for up to 2035. The demographic bonus is the period when the population of productive age, which is between 15 to 64 years, have a proportion more than 60% of the total population. The momentum of the demographic bonus is an opportunity to prepare a healthy generation of superior quality. On the other hand, if human resources are less productive and unhealthy, it can burden society and the country. That is why preparing a healthy and productive generation from an early age is essential. That is the reason why we have to do the screening program, and we have to make it succeed. So WHO in 2015 said around 15% population have significant mental disabilities, and about approximately 5% of it is children. And so this number may be considered small, but a child who is mentally disabled requires special attention, unlike other normal children. The incident is difficult to know because mental retardation is sometimes not recognized until the child is older and the damage is already irreversible. So one of the causes of mental retardation in children is congenital hypothyroidism. And the prevalence of congenital hypothyroidism worldwide is around 1 in 3,000 live births. So when I see this picture or these tables, I feel pretty sad at the moment. At the beginning, I feel sad. Indonesia only introduced a screening of hypothyroid congenital hypothyroid in 2014, while the other country has gone long way back. I mean, Thailand already some from congenital hypothyroid, G6PD deficiency, congenital adrenal hyperplasia, PKU, phenylketonuria, they have already do the screening, and with the coverage of screening up until 94.1%, while in Indonesia we have less than 3% coverage. Can you imagine that only about 3% of our babies got screening program and only one kind of disease? So that's pretty upset. That's pretty upset, I think. So this is the result. After 2014, we introduced this. We started checking perform the screening program of congenital hypothyroidism, and the coverage is a little bit below 3%. Not until this year, we have already reached 11.38% coverage. So I think I'm a little bit happy about this. So in the prevalence in Singapore, 1/3,000 worldwide, but in Indonesia, 1/7,301. But that is because the coverage is only 11%. So maybe if we increase the coverage, maybe we will get a smaller number. So what's next? We're not talking about congenital hypothyroidism today. Again, now we're talking about critical congenital heart disease. Okay, so the number may be small, yes, but it can cause a serious complications. In Indonesia, according to HWO in 2018, death rate of critical congenital heart disease is about 15 over 1,000 live births. Slide. So in Indonesia, so this is the critical congenital heart disease prevalence. So 1% of neonates can be born with congenital heart disease. Out of this 1%, 25% of them can be born with critical congenital heart disease. So 1% out of 100% got congenital heart disease, and out of that 25% are critical congenital heart disease. So let's say if in Indonesia there are 5 million newborns each year, around 50,000 are born with congenital heart disease, and 12,500 of them have critical congenital heart disease. That's a big number, and you won't be laughing when you know that your children got the congenital heart disease. Maybe we can say it's only 12,500 over 5 million, but we're not going to laugh if it happens to us. Delayed diagnosis of congenital heart disease causes significant morbidity and mortality. A study conducted by Murni in Sarjito Hospital, they found that delayed diagnosis by doctor was the most common cause why it's critical, followed by delayed diagnosis related to midwifery care, financial problem, referral or follow-up problem, and social factors. So late diagnosis is becoming the cause of death in this patient with congenital critical heart disease. So what we can do? We have the modality, we have the tools, we have pulse oximetry, and it's not cost too much. According to the US, about the cost for this screening with pulse oximetry only about $5 until $6 per neonates. It's about 75,000 until 90,000 rupiahs for each baby, compared to when they delayed referral, which cause disability, they have to spend about $34,857,000 for one patient. So screening is good. Let's do it. And then we reach to the government policy. So in slide. In order to improve public health and health services toward universal health coverage by strengthening basic health services and encouraging promotive and preventive efforts, supported by innovation and the use of technology, the Ministry of Health sees the need to improve and transform the system. So this one called sixth pillar of health system transformation, which is in primary services, referral services, health resilience systems, health financing system, and human resources, as well as health technology. So immunization is a part of the primary immunization is among the primary prevention by including 14 antigens and such. And the screening program is in the secondary prevention, as well as screening of 14 diseases which cause death in the highest in every age group. Right? So what can we hope for the future? Future hopes for a better tomorrow. Hope more screening panels for newborns like G6PD deficiency, congenital adrenal hyperplasia, phenylketonuria, homocystinemia, hearing and vision screening for premature babies, because many babies in Indonesia born premature, and we don't want them, okay, they can live, but they go blind or they go deaf because of treatment or other. So we want them to, okay, they're born as premature, as a low birth weight baby, but we want them to have a good quality of life for the future. And we also hope that more screening for metabolic disease. We cannot also always think of curative. We have to begin to think about promotive and prevention. We have to detect it early, not make it to the last stage or the terminal stage. We don't want that. And we hope more antigen for national immunization program can be introduced in the following years. Right. So these are some take-home messages I can give you for today. I hope what I have been trying to say can reach you, can understand what I've been saying. So working together to support government program is the health sector, in the health sector by actively participating in the program. So we have to participate and we have to make it work, because this is for our children, for our future. Increasing immunization coverage to boost individual immunity and herd immunity. So maybe, I mean, it's always there. Those people who against vaccination, it's always there. But we have to do what we can. So we cannot focus on those who cannot, but we have to focus on what can we do for this. And increase the type and coverage of newborn screening to enable early detection of abnormalities that can disrupt a child's growth and development. So we need to know early, we have to screen early so we can detect what can disrupt the growth and development of these children. So that's it for today. I hope what I sent today can get to you, you can understand, and you can take some messages from these presentations. And I'm sorry if there's some something wrong with my speech or presentations. I hope you can accept that. Thank you. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Shatira, for the very great presentation. And we'll continue with the last presenter, the last but not the least, of course, Ibu Wahida binti Daud. She is from Malaysia, and she is currently a practitioner in nursing unit from USM Hospital, Kelantan, Malaysia. And her presentation is about regarding the implementation of spiritual care in nursing. Please welcome our speaker, Ibu Wahida binti Daud. Time is yours, Bu.
Assalamualaikum and a very good morning. Can you all hear me?
Very clear, Bu.
Okay, thank you very much. ربي اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Okay, I would like to thank the organizer for giving me an opportunity to share this topic with the audience today. It is a bit dry topic, but please bear with me for another half an hour. I will make it short and sweet. Okay, let me share the presentation first. Okay, let me start with introducing myself. I'm a nurse supervisor of nursing unit in the hospital USM, Kelantan, Malaysia. Okay, my topic today is introduction of spiritual care and the definition of spiritual care, spiritual distress, applying the nursing process, and the take-home message. Okay.
Ibu Wahida, excuse me. Oh yeah, it's on already.
Can you hear me?
It's clear, bro.
Okay. The spiritual care actually is an important component of holistic care. As a nurse, we are the intent of spiritual nursing is to assess, diagnose, and respond to the spiritual needs of each individual patient. Because a patient has different spiritual needs that may not be related to our religious preferences. Okay, NHS Education of Scotland in 2019 defined spiritual care as recognize and respond to the needs of human spirit when faced with trauma, ill health or sadness, and can include the need for meaning, for self-worth, to express oneself, for faith, support, perhaps for rites or prayer or sacrament, or simply for a sensitive listener. Spiritual care begins with encouraging human contact in compassionate relationships and moves in whatever direction it requires. Okay, people always misunderstanding spiritual care with the religious belief. It is not actually the religious belief and practices, but it is about imposing your own belief and values on another. So this is not a specialist activity. We as a nurses also can identify the spiritual distress among the patients. And it is also not the sole responsible for religious officer only. Okay, before we go further, let us see what is the spiritual distress definition. Again, NCCN, the Natural Comprehensive Cancer Network, define spiritual distress as a multifactorial, unpleasant emotional experience of a psychological, include cognitive, behavioral, and emotional, also social, spiritual nature that may interfere with the ability to cope effectively with cancer, its physical symptoms, and its treatment. For example, if the doctor explained to the patient that patient had cancer, automatically patient will be sad. And it is one of the symptoms that a patient develops spiritual distress. And distress extends along a continuum ranging from common normal feelings of vulnerability, sadness, and fears to problems that can become disabling, such as, like I said just now, depressions, anxiety, panic, social isolation, existential and spiritual crisis. Okay, this spiritual distress, if we do not take care, it will impact ability to experience and integrate meaning of patient's life. Then patient will have a lack of connectedness with self, others, God or transcendent, and to others significant or separate. Patient will feel pain deep in the soul, and this spiritual suffering can manifest as lack of meaning, hopelessness, grief of loss of future, worry about forgotten, and concern for loved ones that will leave behind. Okay, for our information, there is a bit high in the incidence of spiritual distress. A few research has been done. For example, Orders 2018 saying that for the inpatient setting, it ranges from 60% to 60%, and 90% of patients had experienced spiritual pain at the same point of their life. And the study done in Switzerland, about 60% of patients in geriatric rehabilitation reported the spiritual distress. In Israel, 20% of patient cancer in outpatient setting reported the same. And India, a bit high, is about 73.3%, found that their illness unfair to them, and 83.3% keep wondering why illness had happened to them. This spiritual distress can impact the patient's health outcome, because spiritual distress associated with poorer health outcomes, including greater physical pain, depression, anxiety, poor emotional well-being, general distress, and others as in the slide. Okay, as a nurse, what we should do about this? The role of the nurses in spiritual care. So as a nurse, we must adopt a caring attitude and disposition, recognize and responding appropriately to customers' need, use observation to identify clues that may be indicative of underlying need, give patient time to listen and attend to individual patient's need, being aware when it is appropriate to refer to another source of support. For example, religious officer, counselor, another staff member, family or friend. Okay, let me give an example. In my hospital, we have the Islamic Center, which is under the hospital, they have the already certified with the ISO 19 Sharia-based quality management system in 2021. So easy for us to refer the patient if patient had spiritual distress. This under the Sharia control, critical control points, which is there is 5 domains: halal, haram, aurat, mahram, and muamalat. So as the nurses, we have our nursing process. We are applying the nursing process for the spiritual care also, like our other nursing care. First of all, as we know, the nursing process will start with assessment. There is 2 types of assessment. It is subjective assessment. The first is to providing the first step in providing effective patient care is to do a spiritual assessment. Involve the patient we ask the patient open-ended questions. The example of spiritual assessment tools we can use is FICA, or FICA Spiritual History Tools, which was introduced by Buchowski in 1996. And the Hope Spiritual Assessment Tool by Anda Raja and Hart in 2001. So this is the example of FICA Spiritual History Tools, which we ask the patient about their faith or belief, what are the spiritual belief, the importance and influence of the spiritual to the patients, the community support to the patient, and let patient address what support that we can give to the patient. And the next is HOPE, HOPE, Hope Spiritual Assessment Tools, which this HOPE for the H pertaining to a patient's basic spiritual resources, such as resources of hope without immediately focusing on religion or spirituality. The ONP is referred to areas of inquiry about the importance of organized religion in patients' lives and specific aspect of their patient. And the E is effect of spirituality on medical care and of life issues of the patients. So the objective assessment, observe the patient cues indicating difficulties in finding meaning, and monitor for supportive relationship from the significant others. Okay, after we do the assessment to the patient, we must formulate the nursing diagnosis to to plan the patient's needs. The North American Nursing Diagnosis Association International, NANDA, because here we use the NANDA one for nursing diagnosis. This NANDA consolidated this nursing diagnosis into 4 for the spiritual care, which is readiness for enhanced spiritual well-being, spiritual distress, impact religiosity, readiness for enhanced religiosity. Any of these diagnoses actually can be applicable to a patient when developing plan of care to meet a spiritual need. Okay. So for the outcome, we set the goals, and SMART outcomes should be customized to each patient and their situation. The SMART is specific, measurable, achievable, relevant, and time-based. For example, the nursing diagnosis of patient is readiness for enhanced spiritual well-being. The SMART outcome We can write the patient will express a sense of meaning and purpose in life by discharge. So, after we formulate the nursing diagnosis, we can plan the intervention for the patients. Such as take cues for the patient, ask the patient how you can support them spiritually, support patient with their own faith tradition, listen to a patient's fears and concern, pray with a patient if requested, or you can provide someone who can join the patient for pray. Share an encouraging tone of word, use presence and touch. This is the very important for the nurses. And listed below are the nursing interventions to provide spiritual support, which is we actually do it every day, but we don't realize. We as a nurse, we give care to the patient, but the most important is we must listen to what patient needs. Okay, for example here, before we send patient to OT, the nurses, the patient, and the doctors will recite a prayer before we go to OT, before patient sent to OT. And before every procedure, we will recite Bismillahirrahmanirrahim in front of patient, so that patient will feel secure. Okay, so after the planning, now we are implementing the interventions. Nurses should support patients' spiritual and religious preferences if not indicated with the medical advice. Nurse also should respect and listen to patients' expression of belief. We are lucky here because the Kelantan population is more on Muslim, so their belief and the nurses' belief are the same. If there is non-Muslim like Buddhist or Hindu, we will ask the patient what their preferences. If they want to call the monk to come to the ward, and we will help the patient to call the monk to the ward to recite the prayer. And last one is the evaluation. After we did all the intervention and implement the intervention, we must evaluate the effectiveness of our intervention to promote the patient's spiritual health. Review the patient progress, then personalize outcomes that customized to the patient situation. As a conclusion, meeting the spiritual needs of the patient can be very rewarding experiences for both the nurse and the patient. Again, to provide effective spiritual care, the nurse needs to be mindful of her perceptions as well as patient's perception of death and dying. Conduct a spiritual assessment, recognize the difference between religious and spiritual needs, identify appropriate spiritual care, and determine when it's appropriate to deliver spiritual care to the patient. Healing does not mean that cure will occur, but the heart will come to rest. With that, I thank you.
Thank you very much for Madam Wahida Dawood for the great presentation regarding the spiritual spiritual care in nursing and how it is implemented in for the patients in the hospital. All right. Let's move to the discussion session, and I'd like to invite the participants to participate in the question and answer sessions. For the participants who have questions, please may use the raise your hand or put your question in the chat message. For the first round, I will invite 3 participants to ask questions to our speakers and to whom you address your questions.
Can I ask my question or can I wait?
Okay. Okay, I invite Jessie to deliver your questions. Okay.
Thank you very much. Actually, I have 2 questions. The first question would go to Ibu Wahida Daud, and then the second question would go to Madam Yiying Jiang. So apologies. Are you hearing me? Are you hearing me? I don't think so. Okay, let me just type it. Let me just type it in the chat.
Yes, we can hear you.
You may repeat your question. Okay, I will check in the chat for the questions from Jess. Okay, we have here okay, in the chat we have some questions from the participants regarding the spiritual cares. The first questions. The question is the question is addressed to Madam Wahida, and the question is, why do you think you take a religious approach rather than psychology when patients show feelings of sadness and feeling of hopelessness? Okay. The second question also addressed to Madam Wahida from Ani Aul Ilmi. The question is, does all spiritual care let's see. The second question from Ani Aul Ilmi. From Jesse from Gambia. The question goes to Ibu Wahida Daud. And given the diverse spectrum of spiritual belief practices and their impact on health outcomes, how can nurses conduct comprehensive spiritual assessment that go beyond superficial inquiries, ensuring a deeper understanding of a patient's spiritual needs? And furthermore, how can this understanding be translated into individualized care plans that respect and integrate a patient's spiritual belief into their overall care? And the third question is, does all spiritual care intervention that you have been implemented in your hospital, that you mentioned in your presentation, that related to religion or spiritual belief? These three questions addressed to Madam Wahida Daud. Please, time is yours to respond to those three questions. Madam Ibu Wahida Daud. Yeah, there are three questions for you.
Ibu, ada dengar suara?
The first is regarding what
Ibu
do you think
Nurdiana, I
you
cannot
take
hear
religious
you.
approach rather than psychological approach? Madam Wahida, please unmute the, oh yeah, it's already unmute the speaker. It's very interesting topic related to the spiritual care for the patients in the USM hospital and how to take care of the patients with the spiritual approach. Yeah. Okay. I think there is some problem with the audio. So let's check the another questions from the participants. Yeah. There is one question for Dr. Satira. Hmm. Yeah. Yeah. For Dr. Shatira, the question is, as a lecturer, how do you think university should be able to support screening programs so they are not left behind in accelerating screening apart from burdening it with the government?
All right. Thank you, Mr. Ilham, for the questions. So, as a lecturer, what can we do to support the screening program so that they are not left behind in accelerating screening apart from burdening with the government? So, as a lecturer, we must provide the latest information to our students. So, through our lecturers, through our seminars, starting from the latest policies. Because policy in healthcare often changes according to the leader. That's a fact that we all have to live with it. And the second, we have to introduce the students to the community from the start. So they don't wait until they graduate to get to the community. We introduce them since they are still as a student. We we take them to the public community health center for example. Then they can share their knowledge for the people in the community, and they can influence the people around them, their close family, or their family, or the people, their relatives about this program. So we always find community which don't accept any health programs. They don't accept immunizations. They don't agree with the screening programs. They don't want their children to get injected because they don't want the babies to get sick or to get cry. So they tend to refuse that kind of program. So what we can do as a teacher, as a lecturer, or as a medical or health students is that we can introduce this program slowly to our circle. We begin with our people, with our family, with our community, with our friends who outside the health and medical community. We tell them about the importance of the screening program, that this disease can be detected early since they they get birth. And if they cannot be detected early, they will come later with clinical symptoms. And when the clinical symptoms is already appear, it's already too late. For example, patients with congenital hypothyroidism, they may not manifest the clinical signs of congenital hypothyroidism when they first born, but 3 or 4 months after, they will come to us with the prolonged jaundice. They cannot with constipations, and people with us delayed delayed development. It's already too late. We gave them therapy, but they may not actually achieve their full potential as a child. So we are late, and we can do this screening program, detecting this disease early, and of course we will. It's a life-changing games. I mean, it's very, very important to do this. I think that's all.
Thank you very much, Dr. Shatira, for the explanation how lecturers involved in the program for the specifically the low coverage of the immunization in Indonesia. All right. Then the next question is from. Thank you very much, Dr. Shatira, for the comprehensive explanation for the question from Ilham. And the question for Professor Ying Jiang, right now she has another meeting, so she will respond. So this question for Professor Ying Jiang will be notes, and then will be given and will be later for the participants to answer the questions. And then for the another question for Madam Wahida Daud, is the audio is already okay, or we might answer the question through the chat if there is a problem with the audio. Yeah. There are two questions for Prof. Ying Jiang and from Andi Susilawati, and also from Jessie. We will forward your question to her. And then for yeah, for Professor Ying Jiang. Oh, the absence link. Okay. Another question for Dr. Shatira is that what is your opinion about 1,000 like 1,000 days, yeah, of birth period? Is it include in the program in the faculty or the department or medical department?
Yes, thank you, Dr. Nadia. So 1,000 days of early lives is actually one of the programs in our study program. So this program is by actually performed with introducing the students since they're in the third semester to the community. So each students have to follow up a pregnant woman from since they got pregnant until they give birth to their children, to the child until 2 years, until the child is 2 years of age. So one child, one student for one mother, and one children and one child. So they have to follow up the mother during their pregnancy. They prepare them for uh, informations. And if they have problems during their pregnancy, they will suggest the mother to go to the clinics or to the public health center or find professional help for their problems. And the children as well, they have to monitor the children up until they are 2 years of age. So they can, by doing this, we hope we hope that we can prevent loss in immunizations or stunting in these children, because the student must measure their body weight, height, and the development of this child during 2 years of their life. So if all the university conduct this program, so maybe we can cover all the system since they are birth, since the beginning. We can detect early problem in child and in child health, growth and development. So it's a very good program, and I think we will continue to do this in the future. Thank you, Dr. Nadia.
Thank you, Dr. Shakira. Another question for Professor Ying Jan, that can you share best practice from your country about the way to prevent non-communicable diseases? So all these questions will be forward to Professor Ying Jiang, and then the response will be given back to the participants. For, I think similar with the question for Madam Wahida Daud, because right now still cannot hear any discussion point from us. So the question also will be forward to her and then to give response. But it's gonna be better if Madam Wahida can answer through the chat. Okay. Another question from Jesse for Dr. Shatira. What comprehensive strategies can be implemented to address the multifaceted barriers ranging from vaccine hesitancy and access disparities to misinformation in order to achieve widespread of vaccination coverage, and effectively eradicate or significantly reduce the incidence of vaccine preventable diseases, not only in Indonesia, but especially in the more wide scope in the global.
Yes, thank you, JCB from Gambia. So it's a very interesting question, and I think this is what we all have been asking for ever since the beginning. So the comprehensive strategies, for once, we have to think that this is not just one person job. We need to implement interprofessional education and interprofessional collaboration. So we have to all work together. This is not just the job of a doctor or a nurse or a midwife. We have to work all. And after that, we're not only talking about healthcare providers. We have to think about the policymakers. So the policymaker have to think that this is not just about health issues. I mean, we can think about health issue, but there's also finance problem, the facility problems, and that's the government area to finding the solution. So we began with the policy. We began and then we go to the stakeholders, all the stakeholders, the health ministry, the finance ministry, and we also because like in Indonesia. And because of that, we excuse me, and because of that, we need a comprehensive collaborations with all, and then we work together with the other nations. I mean, we cannot all do it ourselves. Sometimes we need help from other countries, in case of vaccinations. Maybe we can, when Indonesia unable to make their own vaccine, maybe they got vaccine from other countries. And then the third one, we also put religion in this. I mean, in Indonesia, we have many religions and many ethnics, and everyone thinks differently. And we need collaboration from all the religious religion to make sure this program is successful. So I think this is a very big cases, and we have to work together. Thank you.
Thank you very much, Dr. Satira. And we still have about 5 minutes before we 5 to 10 minutes before we finish this session. If there is any burning questions in your head, please type in the chat message, or you may speak directly to our speaker who is still here with us today, Dr. Shatira and Ibu Mariam Mohida Daud. Okay, Andi Muhammad Fauzul.
All right. Thank you very much for the opportunity given to me. First, can you hear me? My voice? Is it clear? Jake, can you hear my voice? Miss Nordiana? Jake? Jake? Can you hear my voice?
There's some problems in the technology. Okay, Muhammad Fauzul.
All right. Can you hear me? Can you hear me?
Your question is addressed to Dr. Shatira.
Yeah. My question for Dr. Shatira Jalaluddin. All right. Thank you very much, Dr. Shatira. Dr. Shatira, SPA, MCAS from Medical and Health Science Faculty, right? Alauddin State Islamic University, Indonesia. I'm very interested with your presentation. That's insightful and wonderful presentation, Doctor. Right now, I have several questions based on your presentation before. Actually, I have two questions about your explanation about children, right? So, the first one, I want to know about your perspective. What's the by your POV, doctor? What's the biggest problems in Indonesia in children problems and what's the struggle and what's the challenge uh, to fix all of this problem, and what's the program from government take or choose to fix all of the problem, and by your POV is a right ways is a right way to fix all of this problem. That's the first question, Dr. Shakira. And the second question is, have you ever heard about the government program regarding stunting elevation by requiring the daily giving of eggs to children? By your POV, doctor, by your perspective, how we make sure or how we ensure that that's problem it works in all of the island in Indonesia, and if and are those steps is a right, or how to make the program successful by your POV, and is it uh, effective for fix that problem, especially specifically to fix the stunting problem? I think that's enough for my question. Thank you.
Thank you for the questions. There are two questions. The first is about what is the problems and the challenges to fix the related to the immunization, the low coverage of immunization, and the second one is about the stunting elevation and how to fix the problems. Okay, I hand move on to the second.
Like, thank you for Andi Muhammad Fauzul. So the problems about the challenges about the coverage. Okay, so the Indonesian government already issued increase in the number of antigen in routine immunization in Indonesian children. First, we only have DPT, hepatitis B, HIV, polio, BCG, measles in the 2000s. And then we began and moved with the additions of rubella, and then to the PCV, rotavirus this year, and Japanese encephalitis. So we're working on it. So I'm not saying that we are in a very good position yet, but I'm saying that we are working on it. We need the support of all people about this problems. And about the coverage, we always find in the community people who are against vaccine. That is undebatable, and we cannot escape from that. But what we can do, if we people who know about this, the importance of immunization and vaccination, we can always work from our circle. Make I don't know. Maybe I think like discussions with them, those people. We begin with our close community, and then we can go to our work and school community. We begin with ourselves, that we know that this thing is important, and we know that this immunization is important for the future of our children. So we have to make the other people understand about that. But if we still they still cannot understand about that, at least we have tried. That's one. And the second one, I think the government still have to increase their the accessibility and the size of the vaccine they deliver to the periphery. So many people want to go to the primary health center, but they didn't get the vaccine because they are out of stock. So that kind of thing needs to be taken care of by the government. The second one, because Indonesia is a religious country, so I think we have to include the religious leader to for the approach of the people with who cannot take the immunization program. So we use all the peoples we can have. We get all the help we can have to make sure this program is successful. And about the stunting problem, I think every region in Indonesia have their local wisdom. I'm saying local wisdom. They have the benefit. They have what they have best, and I think to prevent stunting, we have to optimize what we have best. Like for example, when in Papua they don't have lots of rice, they can use sagu or corn to to increase their variety in their meals to prevent stunting for their children. So the use of local wisdom in preventing to decrease the stunting rate in our children. And then, like I said, we have 100 days of early life programs in our study program. If every university perform this, one student follow up a close monitoring of one pregnant woman, and they can detect early problems in their child, and they can prevent stunting from the early age. So I guess the combinations of between the government, the education, the health, the religion, all stakeholders will give us a better successful rate for our program. I think it's like that. Thank you. Thank you very much, Dr. Shatira. Very comprehensive. Comprehensive answer from Dr. Shatira. So not to include only the government, but all elements of the community to participate. Because there are pro and cons regarding the whether they want to get the immunization, vaccination for their children or not. So religious leaders, of course, need to be involved in the programs in the community, not only partial. All right, we are just about to end this meeting, this sessions, but how many time left for us? Let me check. Is there any question for our speakers? One last question. If there is any questions from the participants? One more questions for Dr. Shatira, and then as you explained before, that the question is about how did Indonesia effectively engage the first community, including those influenced by cultural beliefs. Indonesia is very multicultural, so how Indonesia from Indonesia's experience to overcome this? What's the approach implemented? Yes, thank you, Jessie, for your questions. Like I said, Indonesia is a very rich in diversity in religious ethnicity, and I think in the child problems, we all have one opinion that we need to do our best for our children, and when something happens to our children, we will try the best for them. And if this happens to our children, maybe we don't want them to happen to other children. So like I said, because we need a the work of many people, many fields. The stakeholders all have to engage in these problems. It's not just the Ministry of Health's problems. It's about the problem of a nation or the problem of the world. So I'm not saying Indonesia is already able to manage all this problem. We still have lots of problems, and every day we face about that. But so many today, nowadays, so many people are really they get they have a better understanding about the problems, so they can relate this problem to their circle, to their community, and we can if there's a good thing about immunizations, we can share it through our social media. We are so connected nowadays. We don't have to visit them or meet them to make them understand. We can all socialize through social media. That's one. And then the second one, there's always a group of people who don't believe in vaccine. That's always happen. Whatever happens, we do. There's always still some people like that. So that's why we need to increase the coverage. So we need to increase the herd immunity. So maybe by that we can protect those people who don't have who's not able to get immunization because of many reasons. I think that's all I can say about this, because we're still handling and we're still struggling and we're still trying to make up our lack, our lack of and we're still trying to be a better countries. I believe. I think that's all I can say for now. Thank you.
Thank you very much for the response, Shakira. And we are just about run out of the time, and I want to thank all these fantastic, our amazing panelists, and for sharing their thought and expertise. I'd like to thank the organizer for inviting me to moderate, and I want to thank to all the audience and participants for all your wonderful questions. Please, one more big applause for our panelists and all of us. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you for amazing moderator, Ms. Nurdiana, to lead the first session symposium today. And also our speaker today, we have also speakers. So let me give a virtual applause for the speaker. Okay, ladies and gentlemen, all the participants, also we have come to the end of the first symposium today, and we also will continue after the workshop, after Jumat prayer, at maybe at 2 p.m. or 1 p.m. 1:30 p.m. Okay. So enjoy the first symposium, and don't forget to join us at 1:30 p.m. for the second symposium today. Thank you. Okay, Assalamualaikum warahmatullahi wabarakatuh. Welcome back to the second session of our international conference today. Second Alauddin Health and Medical International Conference for the second symposium. And the next agenda about the second symposium will be led by our moderator, Mr. Ahmad J, SCAP Nurse MCAP, STCAP MD ATN. And for the second symposium, also we have 4 speakers today. There is Mr. Erman Gadekli, PhD from Health Management, Istanbul Medical University, Turkey. Sabri A.S. Zidan, Pharmacognosy and Natural Product Chemistry, Al-Azhar University, Cairo. Professor Lisa McKenna, La Trobe University School of Nursing and Midwifery, Melbourne, Australia. And the last speaker, Dr. Alauddin Nova Novianti Rahman, SPSC MCAS, from Faculty of Health Science, Mandala Waluya University. And for this session, please welcome to our moderator, Mr. Ahmad J.
Thank you very much for the time from the Master of Ceremony. Can you hear my voice? Okay, the Honorable Person, Rector of UIN Alauddin Makassar, Professor Hamdan Johannes, PhD, and the Dean of Medical and Health Faculty of UIN Alauddin Makassar, Dr. Dewi Setiawati, SPOG, MKes. First of all, let us thanks to the Almighty Allah Subhanahu wa Ta'ala. Because of His blessing, we are able to come here to join the second Alauddin Health and Medical International Conference, Alhamdulillah UIN Alauddin Makassar. Secondly, salawat and salam also delivered to our Prophet Muhammad Sallallahu Alaihi Wasallam, who has guided us from the darkness to the brightness. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, today we have 4 speakers from around the world. The first speaker is Mr. Erman Gadikli, PhD from Health Management, Istanbul Medical University, Turkey. And the second is Mr. Sabri E.H. Zidan from Pharmacognosy and Natural Product Chemistry, Al-Azhar University, Cairo. And the third is Professor Lisa McKenna from La Trobe University School of Nursing and Midwifery, Melbourne, Australia. And the last is Dr. Alauddin Nova Novianti Rahman, SPSI MCAS from Faculty of Health Science, Mandala Waluya University. To the first speakers, it will be delivered by Mr. Erman Gadikli from Health Management, Istanbul Medical University, but I will read the CV of Mr. Erman Gadikli. Mr. Erman Gadikli received the BS degree in economics from Saradinis Technical University in 2013 and the master's degree in management and business administration from University of Eurasia in 2016 and the PhD degree in the health management from Istanbul Medical University in 2020. Through his academic life, he has authored various international proceedings, articles, and books chapters. Dr. Gadikli has been working as an assistant professor at the Department of Health Management, Istanbul Medical University since 2021. His research interests include health management, facilities management, health tourism, health energy, operational research, and mixed research methods. Wow, that is the CV from Mr. Erman Gadikli. Are you with us?
Yes, of course. Is my sound is clear?
Yes, your voice is clear. Okay, Mr. Erman Gedikli, time is yours.
Okay, thank you so much. And let me share my screen with you. Can you check it? Is it applicable?
Yes, is it visible and your face is clear also?
Okay, thank you so much. And before I begin, I would like to pray for peace for the Muslim in Palestine. The current situation has deeply wounded our hearts, as you know. So here again, it is my honor to be invited speaker at second Alhamdi. Therefore, I would like to thank the chairman and the organization committee. So another special thanks to also goes to esteemed students, my esteemed student Sumaya Faka, for being a bridge between stakeholders. So today I want to give some of information about the health and energy with the perspective of One Health framework. So I want to conduct some of researches about this topic after understanding the One Health, and today I will give some of information to you about that topic. The title of this study is Enhancing Renewable Energy Transformation in Healthcare within the One Health framework. So before starting, let me read again what is the One Health. All of you know it, but definitions give us an perspective. One Health is a collaborative effort of multiple health science professions together with their related disciplines and institutions, working locally, nationally, and globally to attain optimal health for people, domestic animals, wildlife, plants, and our environment. Of course, this definition comes from the One Health Commission. So let's talk about the importance of One Health. The human health is closely connected to the health of animals and our shared environment. In world today, the people and animals interact more closely and more often than ever before, sharing the same environment, diseases, and other health issues. Not just the location sharing we are including here, we also sharing our diseases. That is so important, as you know. Each year, millions of people and animals around the world are at risk by zoonotic diseases. Especially, we can include here the COVID-19 period, which was witnessed. So, as you know, the diseases do not recognize borders, and they do not need some of visas. Okay. So, for this perspective, One Health approach can prevent the outbreaks of zoonotic disease in animals and people. So, the One Health approach can improve the food safety and security and economies reliant on livestock production. Also, One Health approach can reduce the antibiotic-resistant infection and improve human and animal health. And finally, this approach can protect the global health security. As you see, there are a lot of ability for One Health approach. But in this study, I want to focus on just health and energy. As you know, energy using directly or indirectly affect the animal health, environmental health, and the human health. So there are three different separate groups here, as you see. The first one is the energy in health facilities, and environmental factors, the other one. And finally, energy and food production, we can see some of results for using energy from perspective of One Health. So let's focus on the energy and food production and make it more clear. The energy used in food production and supply chains directly impacts the human and animal health. Intensive livestock farming practices, which are energy intensive, can increase the disease transmission risks, as you know. So what about When it comes to environmental factors, energy production and consumption are linked to human and animal health. One Health emphasizes considering these interconnected factors for effective health management. And finally, when it comes to health facilities and the using some of energy resources, the energy is crucial for implementing One Health approach. As you know, healthcare facilities rely on energy for effective operation and addressing zoonotic diseases. So we know all of advantages for these renewable energy resources. And let's talk about transformation energy resources for health sector from the conventional health energy resources to renewable energy resources. So One Health, again, is an approach that recognizes interconnectedness of human, animal, and environmental health. And it emphasizes the importance of sustainable energy practices to promote overall health. So the One Health approach recognizes that the health individuals, communities, and ecosystem is interconnected and interdependent. So it makes to us, it makes easy to understand this One Health approach and energy usage. So it underscores the importance of adopting sustainable and responsible energy practices to mitigate environmental and health risks. By prioritizing clean energy, energy efficiency, and promoting awareness of health energy nexus, and we can create a healthier and a more suitable for all living beings on Earth. And also, conventional energy usage in health sector plays a crucial role providing essential services and maintaining the well-being of individuals in healthcare facilities. Sustainability is also important for healthcare facilities, as you know, because these facilities should service 7 days and 24 hours. While there is a growing emphasis on sustainable and renewable energy resources, conventional energy resources like electricity and fossil fuels continue to be mainstay in healthcare industry because these are so cheap according to when we want to make a comparison between the renewable energy resources. And also the infrastructure of cities or any facilities fit for these conventional energy resources. But when it comes to renewable energy resources, there are some of barriers. So in this concept, I want to investigate which topics which is related with health and energy some of researchers and the scientists have investigated. So according to literature review, we want to summarize some of categorization as I listed here. So the subject of health and energy was interested in a lot of research in literature with different variation, as you see. Some of studies focused on examining health effects to carbon dioxide emissions resulting from the fossil fuel-based energy consumption. So the other studies conducted specifically health facility focus more on energy efficiency and also use of alternative energy resources, which is included here some of renewable energy resources. So in some studies, the researchers investigated the energy efficiency with conventional energy resources of facilities, and which are offers healthcare services, medical centers, hospitals, and any other example we can list it here. Some researchers on health and energy have focused on variables that people are exposed to as a result of energy usage and the cost of the environments, buildings, so forth, where they live and getting different services. But all of this is not just related to our research topic. For enhancing these ones, we focused on what is the disadvantages, what is the challenges for transformation from the conventional energy usage to renewable energy usage in health sector. So as you see, I have listed here some of barriers for these transformation processes, policy challenges and legal challenges. These are some of regulation challenges we can categorize. And the other one is irregularity in production, storage challenges, productivity challenges, and distribution challenges, operation and maintenance challenges, and also lack of supporting technology, or also we can including here suitability for infrastructure. So we can categorize all of these ones as a technical challenges. And additional to these, construction costs and capital costs of investments can be listed here for new challenges. So these are also can be categorized as a capital or yes, financial capital challenges. So mainly three separate challenges category we can list it here. As you see, there are a lot of challenges for transformation, but we have limited resources with money, with technological, with regulations. So for this reason, with our limited resources, with our limited regulation, how is it possible? We want to investigate this one. And let me talk about our study. So here, the purpose of study is developing strategy for enhancing renewable energy transformation in healthcare for policymakers. For this reason, we employed an operational research methodology. We can also call this one decision-making methods, multi-criteria decision-making methods. And this is fuzzy analytic hierarchy process. The method was used to determine common wisdom on the subject. Indeed, this method is a powerful decision-making tool designed to address uncertainty and ambiguity in multi-criteria decision analysis. And that is the most useful one. In complex and ambiguous situation, fuzzy HP offers a structured approach to prioritize and make informed choices. So here we have listed some of barriers. How is it possible? What is the common wisdom? Which ways we will follow? So before talking about the results, let me talk about the key concept of AHP and fuzzification. The process starting from structuring, construction, and hierarchical structure. And by this way, we can understand what is the main issue and what is the criteria which way we can make some of evaluations. And then pairwise comparisons we can have. And finally, after collecting data with fuzzy numbers, that accommodates impressive data using fuzzy numbers to represent uncertainty and the vagueness in judgments. So the fuzzification empowered the AHP method, we can say. By this way, the actual results can have an actual decision about this topic. So for this study, we get some of data from different 5 experts. I have listed here the experiences in the field and the specialty and the origin information as you see. So which is the most critical barrier in the transformation from conventional energy use to renewable energy resources in healthcare, our question? I have asked this question all of these experts, and I have listed here what is the barriers. According to this question, we asked these experts, please make a comparison, please make an assessment, which is more crucial for you. So this expert specialty, as you see, including here health management and the renewable energies. So by this way, reaching a common wisdom makes so easy. According to our data collecting and after the AHP analysis, we have ranked all of these barriers. As you see, the most weighted one is irregularity in production. That is also related to sustainability in health services. And the second one is contraction cost. And the third one is policy changes. So actually, when we sum up all of these ones, it's reached to approximately 50% for weight. So this is the most important one. If you want to make some of transformation possible, we should consider first the irregularity in production. I understand from the result of that analysis. So let me focus this result more closely. In this study, I have employed a fuzzy analytical hierarchy process, as I say, to assess and prioritize the barriers and the challenges associated with the renewable energy adoption in healthcare. I sought to understand how renewable energy adoption in healthcare can have a profound impact not only patient well-being, but also on environmental health and sustainability. It also fit for the One Health approach, as you know. So fuzzy AHP analysis has identified several key barriers, each with its own significance in the One Health context. The first one is irregularity in production. That is a technical problem, as you know. So with its high weight, that reflects the potential inconsistency in energy supply from renewable energy resources. If you want to use wind energy, for example, the climate can be changed from day by day, and also polar resources can be changed day by day again. This inconsistency can disrupt the healthcare operations and lead to increased reliance on conventional energy resources with implication of environmental health. And the second one is construction cost barrier, which emerged as a second and the most influential. That is represent a financial challenge that healthcare facilities went to transitioning to renewables. These costs can influence allocation of resources both of patient care and environmental sustainability efforts. And the third one is policies. Policies played a crucial role as expected, as you know, in the One Health approach. Inconsistent or unfavorable policies can hinder healthcare institutions in their efforts to reduce their carbon footprint and promote a healthier environment. The outcomes of healthcare institutions are closely linked to further environmental health. So let's talk about conclusion. Healthcare decision makers and policymakers and environmental health advocates should take note the interdependence among these barriers considered them when developing strategies to overcome the hurdles. Addressing the irregular energy production, managing the construction costs, and advocating for supportive policies are steps that healthcare facilities and healthcare industry can take not only to improve patient care, but also contribute to a healthier planet. So, according to these results and conclusion, I have listed here some of proposals for decision makers or policy makers. The first one is invest in sustainable healthcare technologies. As you see, the first weighted barriers is about the technical issue. So if the governments can allocate more funds for research and development initiatives for this topic, it will be more good for all of world. And the other one is educate and train staff. So providing training opportunities for staff to stay updated on the latest sustainable technologies and practices emerging from R&D efforts. This can empower the healthcare workforce to contribute to health facilities' sustainability goals. Yes, we can technically improve some of technological issues, but when it comes to behavioral issues, it can be made so hard. And the other proposal is financial incentives for green construction. So, and the other one is advocating the supportive policies. This is so important. If the national policy makers do not support these issues, how can we enhance these transformation issues? And finally, engaging the public-private partnership can help the governments making it more rapidly. Because as you know, the second issue is construction costs. So by public-private partnership, it can be more suitable for governments and police and any another countries. So I hope including in the limit or time duration. Thanks for listening, and I can finish here.
Thank you very much for Mr. Arman Yudhikri for your very nice presentation.
Thank you so much.
And we have a session of the question and answer, but in the end of all of the speakers. So maybe you can still stay with us until we have still 3 speakers, and then we can move to the question and answer.
Actually,
Yeah.
Mr. Ahmed, I will attend another conference today. If we have, and if suitable for you, if you have any question right now, I can answer.
Okay, it's okay. Okay, so ladies and gentlemen, now we move to the question and answer for the Mr. Dr. Arman Gedikli. Maybe you have a question for the material. It's about enhancing renewable energy. From the audience, maybe I can see from the room chat. Dr. Arman, we have a question from the participants in the meeting chat. So I will read the first question for you. So we have maximum 2 questions for one speaker. The first question is, Dr. Arman, an interesting presentation. In your explanation about One Health can contribute to preventing antimicrobial resistance. Can you please explain more about good experiences in your place to solve about that issue?
So, especially in Turkey, from the government, there are some of supporting for investments which can enhance to renewable energy resources. And also, universities wants to investigate this topic more closely. As you know, in our university, some of researchers, let me say there's names, Hasan Dinçer and Serhat Yüksel, professors. They are working for these topics. How can we enhance these initiatives more suitable? That is also give us some new technological information. How is it possible? Actually, One Health can collect all of these topics with health. We can easily understand the main topic. By this way, more clear initiatives for health we can conduct. Actually, And we have a lot of way for solving all of these problems, as you know. So also we can enhance the technologies, but when it comes to adapting the humans to them, more hard, as you know. So the attitudes and also behaviors should be more focusing ones for adapting these policies and initiatives.
Okay, thank you, Dr. Herman, for your answer. So we have the last question. So the first question is from Miss Nadia. So the second question is from Mr. Sahrul Basri. Dr. Herman, based on your experience in Turkey, how professional collaboration occurs in the field of environmental health in your country?
In our country, actually, the public health professionals focus on these topics. And the health management departments and health management filed a new in our country for these topics. As you know, the public health professionals just focusing on these issues out of financial issues. But that's true. But the main issue is focusing these issues with financial issues, because that are make easy or hard. So in our country, especially, we want to change this issue. We are trying to change that one. We have a long way. And as I say, the public health professionals can manage these processes, and I and my collaboration wants to help them. By this way, it will be good in future. We also make some of collaboration with your country, with your university, with your scientists. I hope it's answer enough.
Thank you, Dr. Herman, for your nice explanation. So maybe before you leave the room, we have a giving certificate from the committee. It's just by
Thank you so much for your attention.
So I will
Mr.
show
Ahmed.
it in the slides. So maybe you can see in the screen.
Oh, thank you so much.
Okay, so we will send this certificate to you by email.
Thank you so much.
Thank you very much
You're
for your time, Mr. Erman Gedikli from Turkey, and have a nice day.
Have a nice day.
Assalamualaikum warahmatullahi wabarakatuh.
Alaikum salam.
Okay, ladies and gentlemen, now we move to the next presenter. So we have Mr. Sabri Sidan. So before we start, maybe I will check Mr. Sabri Sidan. Are you with us?
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Yeah, I can hear your voice.
Okay.
Okay. Before we start the presentation, maybe I will read the CV of Mr. Sabri Sidan.
Okay.
Okay, so this is the CV of Mr. Sabri Sidan from Al-Azhar University, Faculty of Pharmacy, Department of Pharmacognosy and Medical Plants. So the name is Mr. Sidan Sabri, and from Egyptian, and now current position is an assistant professor of pharmacognosy and medical plants, Faculty of Pharmacy, Al-Azhar University, Asyut Branch, Asyut, Egypt. So the last education is PhD in pharmacognosy of Faculty of Pharmacy in Minya University in Egypt, and also now the position is as an assistant professor of Faculty of Pharmacy, Department of Pharmacognosy, Al-Azhar University in Egypt, and also was a lecturer of Faculty of Pharmacy in Al-Azhar University in Egypt. Mr. Sabri Sidan also has a lot of experience in teaching since in 2012 until now, and a lot of publication, I think. And Mr. Sabri Sidan will talk about the role of herbal medicine in advancing human health. Is that right, Mr. Sabri Sidan?
Yes, right.
Okay, so you can start your presentation. You have about 15 until 20 minutes. Thank you. Time is yours.
Okay. Thank you. Do you hear the presentation?
Yes, I can hear you.
Okay. First of all, thank you for this nice invitation. I will talk today about the role of herbal medicine in advancing human health as part of the One Health approach for global health. So what
your
is
slide, please?
Yes, do you see?
Maybe you can share screen. Okay, now it's visible.
Okay. I will talk about the role of herbal medicine in advancing human health as a part of One Health approach for global health. So firstly, what is herbal medicine? Herbal medicine is a type of complementary and alternative medicine that uses the whole plants or plant parts such as fruit, leaves, flowers, rhizome, roots, and preparation made from plants such as volatile oil or plant exudate such as gum resin for the treatment and prevention of disease. The plants traditionally used in herbal medicine are called medicinal plants or herb. Okay, usually the herbal medicine used alongside the conventional medical treatment to alleviate symptoms caused by the disease or reduce the side effect caused by the treatment. Aromatherapy usually included and diet therapy. Aromatherapy is the use of volatile oil, and diet therapy is the use of daily diet in promoting health. They are also included in the herbal medicine. So what's the advantage of herbal medicine? Most of herbs are cheap and more affordable than conventional medicine. Most of them are effective with rare side effects. The herb usually promote natural healing and strengthen immune system. However, they have some disadvantage. Some of the herb has unpredictable biological effects due to lack of scientific study, and some herb has possible allergies with little regulation of production and quality control. Other herb has possible herb-herb interaction or herb-drug interaction. Some herb lack of specificity, they have general uses. So, how to overcome this disadvantage? For patients, caution should be taken when using herbal medicine. People taking other medicine or suffering from serious disease such as liver disease or kidney disease, or patients with surgery should take care when using herbal medicine. Also, pregnant, elderly, and children should take care when use herbal medicine. It should be under the recommendation of a physician. For industrial pharmaceutical companies or industrial firms, some aspects must be considered before marketing herbal medicine. Firstly, the identity. Each herb should be identified macroscopically by studying their morphological character, microscopically by studying the diagnostic element under microscope, and investigate their chemical investigation. either by chemical test or by chromatographic techniques before launching to the market. Also, the purity should accurately detected by detection of the adulterants and pollutants. The efficacy of the traditional help could be scientifically evidenced by using cell culture, animal experiment, or clinical studies. The safety of herbal medicine should be investigated before launching to the market. So we should investigate the acute and the chronic toxicity of certain herb. The therapeutic dose and toxic dose should be determined accurately, and the duration of administration should be determined before launching to the market. Some herbs has general uses and may be useful for many diseases. This herb usually improves the immune system or has antioxidant activity. Also, aromatherapy improves the general health of a human being. Other herb has some specific use for certain diseases, such as common cold and flu, diabetes, hypertension, constipation, hepatitis, gout, and rheumatoids. I will talk about antioxidants and aromatherapy as a general uses of some herb, and I will talk about laxatives as a specific use of other herb. So, antioxidants. Antioxidants are one of the immune system weapons that it used to protect the body against oxidative damage from free radicals. Free radicals or reactive oxygen species usually generate from cell metabolism, ionizing radiation, UV light, inflammation, or some pathogens. These reactive oxygen species initiate what's called oxidative stress, which damages the cell membrane, DNA, and protein. The body usually fights the reactive oxygen species by DNA repair mechanism with the aid of antioxidants. Also, antioxidants called reactive oxygen species scavenger. The role of antioxidants in fighting free radicals includes the donating electron or proton to the unstable molecule, which is called a free radical, to make it a stable molecule, convert it from unstable molecule to a stable molecule. So protect the organelles of the cell from the free radical attack. I will show some of the natural antioxidants, such as polyphenols. Polyphenols are phenolic compounds usually have many acidic protons. This proton can be easily donated to the free radical, stabilizing them. And the beauty of the antioxidants and the polyphenols that itself doesn't become a free radical because it can stabilize themselves by resonance of the Lombe. Some of the natural polyphenol are flavonoid, phenolic acids, stilbene, lignan, gingerol, curcumin, and flavonolignan. Flavonoids is two phenolic rings connected by 3 carbon atoms, forming a heterocycle. Most of flavonoids are present in tea, green tea, citrus fruits, onion, and apples. Isoflavonoids are present mainly in soybean and lentils and peas. Most of the flavonoid has antioxidant activity. Phenolic acids. Phenolic acids are derivatives of benzoic acid, such as vanillic acid, present in red fruits and onions. Other are derivatives of cinnamic acid, such as caffeic acid, present mainly in Echinacea hale. Stilbene are two phenolic rings connected with each other by methylene bridge. Such as resveratrol, which is present largely in grapes. The resveratrol has potent antioxidant activity. It sensitizes in response of the infection or injury and act as antifungal phytoalexin. Lignan are dimer of phenylpropanoid. Lignan are dimer of phenylpropanoid, mainly present in linseed. Gingerol is the pungent, is the active constituent responsible for the pungency of rhizome of ginger. It has antioxidant and anti-inflammatory activity. There are many types of gingerol according to the side chain. Curcumin is dipyrrolomethane. Dipyrrolomethane present mainly in curcuma longa or called turmeric. It has excellent scavenger of reactive oxygen species. Curcumin increase the glutathione reductase levels in the epithelial cell and lowers the reactive oxygen species production. Because the glutathione reductase is the natural antioxidant synthesized in the human body from the liver. So increasing the glutathione level by curcumin lowers the reactive oxygen species and protects the body from free radicals. Flavanolignan such as silimarin, silimarin is a mixture of flavanolignan present in the fruits of Silybum marianum, family composites. Silimarin usually increases the activity of antioxidant enzymes and reduces the fat deposits in the liver. So silimarin usually has hepatotoxic principle. Other type of natural antioxidants are organosulfur compounds, such as allyl sulfide, present mainly in garlic, Ilium sativa. It has antioxidant and anti-inflammatory activity. The reason for the antioxidant activity of allyl sulfide is the lone pair present in the sulfur compound in addition to the double bond. Vitamins are micronutrients required for the proper functioning of the body antioxidant enzyme. The most important vitamins in antioxidant activity is vitamin A, vitamin C, and vitamin E. Vitamin A mainly found in sweet potatoes and carrots. It's found in three forms: retinol, dihydroretinol, and hydroxyretinol. Vitamin C called ascorbic acid. It's water-soluble vitamins and prevent some of the DNA damage. DNA damage are contributed in the aging processes and several other diseases such as heart disease and arthritis. Preventing the DNA damage reduce the aging processes and may be protecting against heart disease and arthritis. Vitamin E. Vitamin E is a lipid-soluble vitamin, consists of 8 types of tocopherol. It present mainly in almond, safflower, and wheat germ oil, in addition to nuts. Due to their lipid solubility, it has the ability to protect the lipid cell membrane from lipid peroxidation. Carotenoids are fat-soluble colored compounds. It has antioxidant activity due to conjugation of many double bonds. They can stabilize the free radical by donating electrons to the free radical and stabilize them. Itself can be stabilized themselves by resonance between the double bonds. Examples are beta-carotene, which present in green and leafy vegetables, lycopene, which present in papaya, pink grapefruits, lutein present abundant in green leafy vegetables. It specifically protects the retina against harmful action of a free radical. Zeaxanthin found mainly of corn and saffron and paprika. It has potent antioxidant activity. Other example of natural antioxidants is essential oil. The essential oils obtained by steam distillation extracted from plant parts such as flower, fruit, bark, root, and seed. They have small molecular size and lipid solubility, so it can penetrate the skin tissue and the cell membrane easily. So it can enter the cell itself and prevent mutant antioxidants inside the cell. Because some herb has antioxidant activity, it can be useful for many diseases, such as cancer prevention. Number of phytochemicals such as genistein, T polyphenols, and the soy isoflavone have anti-carcinogenic and anti-mutagenic effect. Antioxidants in inflammatory disease. Combination of vitamin E, vitamin A, vitamin B can reduce the free radical to react with the lipid and the protein, so they can protect the cell membrane from lipid peroxidation. Antidiabetic and diabetes management. Isoflavones such as genistein and diazine present in soybean, in addition to lignan present in flaxseed, can helpful in diabetic management. Antioxidants and neurodegenerative disorder. Resveratrol present in grape has a protective effect against Alzheimer's disease. In kidney disease, a combination therapy between antioxidants, minerals, and vitamin B complex used usually to aid the patient with nephrotic syndrome. Lung disease. The lung is the most organ in the body exposed daily for free radical due to pollution, tobacco smoking, fuel emission. So the lung is always at risk of oxidative injury. Daily consumption of antioxidants may protect the lung from this oxidative injury. Antioxidant in aging. The aging processes usually include measurement of age-associated oxidative stress. So treatment usually include dietary and pharmacological antioxidants. Antioxidant in pregnancy. Some reports indicate that blood levels of lipid peroxidation products are elevated in pregnancy. So it has been suggested that reactive oxygen species play a role in the etiology of this disease. To overcome this disease, natural antioxidants should be intake in the diet daily. Another example of general use of herbal medicine is the use of aromatherapy. Aromatherapy is the use of essential oil from plants for healing purposes and improves the quality of life. Essential oils aid in the treatment of infection, stress, and other health problems. The essential aromatherapy may apply as massage or during the bath or inhaled from a specific room, such as room freshener filled with volatile oil. In general, aromatherapy is the pain-enhancing mood and promote a sense of relaxation. For example, rose and lavender volatile oil reduce the pain during delivery. People suffering from depression feel some relaxation when you use volatile oil as aromatherapy. Topical massage with chamomile oil reduce the pain associated with rheumatoid arthritis. Also, people suffering from prolonged headache usually feel better when using peppermint oil as massage. But some aromatherapy should be contraindicated in some cases, such as pregnancy in the first trimester, people with chronic asthma or allergies, or people suffering from seizure should avoid all essential oils. People also suffering from high blood pressure or hypertension should avoid essential oil, stimulating essential oils such as rosemary and lavender. I will talk about the laxatives as a specific use of herbal medicine. Laxatives are drugs taken orally to evacuate the bowel and used generally for the treatment of constipation. Natural laxatives may be stimulant laxatives or bulk-forming laxatives. Stimulant laxatives such as senna, rhubarb, frangiula, and aro usually contain anthranoi content. The effect of anthranoi, it stimulates the intestinal motility, inhibits the reabsorption of electrolyte and the fluid from the colon, thereby increasing the volume of the intestinal content and the intestinal filling pressure. For example, senna has anthraquinone dianthrone such as sinusoid A and sinusoid B, and zerglycoside. Its potent laxative has effect of 5 to 7 hours. Large doses work faster but may cause abdominal pain. Another example, rhubarb contain purgative anthranoi such as rin, which is dose-dependent purgative. It can be taken for extended period of time, so it's more suitable for elderly patients. Aloe has hydroxyanthracene derivatives used as laxatives, but in high dose it has abortifacient effects, should be not used during pregnancy. Another example of stimulant laxatives is the castor oil. Castor oil composed of triglyceride of resin oleic acid. In the intestine, the triglyceride converted by pancreatic lipase to resin oleic acid and glycerol. Resin oleic acid reduces the absorption of fluid and electrolyte and stimulate intestinal peristalsis. Bulk forming laxatives. These are bulking agents with high percentage of fiber and rich in polysaccharide. These fibers and polysaccharides inside the intestine absorb water and swell in the GIT, increase the stool volume, resulting in stretch reflex. So stimulates the intestinal peristalsis. The advantage of bulk forming laxatives it's free from any side effect, so can be used continuously or for long time. The disadvantage is that it need many days to work as laxatives. Example is linseed, which has polysaccharides such as hemicellulose, cellulose, in addition to lignin and fatty oils. The presence of fatty oils in linseed provide additional lubricant for the larger stool mass. Hence, the two action of linseed as bulk-forming laxatives and lubricant complement each other beautifully. A precaution, the linseed should be taken with a large amount of fluids to avoid obstructed ileum. Finally, plantago or psyllium constitute high percentage of mucilage, so have high swelling factors. It's more suitable for pregnancy, hemorrhoid, and anal fissures. So the future recommendation of using herbal remedies for One Health approach. For natural product chemistry, they usually use traditional herb to investigate their phytochemical compounds and biological properties. This is called phytotherapy. For healthy people, we recommend including the antioxidant drinks such as green tea and antioxidant foods such as fruit and vegetables in daily product as a protection. For diseased person, the herb may be dangerous when using during serious conditions such as liver and breast, so should care. Aromatherapy aid relaxation and improve your mental health. Try it once at least. Thank you for your attention.
Wow, that is a very nice presentation from Mr. Sabri Zidan. Because my background is nurse, from your presentation, now I have an improvement knowledge about the herbal medicine itself. Because we know that maybe the people, it's difficult to find the medicine itself, and some people don't know that actually there is a lot of plants that can be used as a herbal medicine.
Okay, thank you.
Yes, and from your presentation, you talk about herbal medicine also can improve, improve natural healing from the body itself, and also it needs a safety and purity process to use it.
Okay.
So, Mr. Sabrisidan, now we move to the question and answer session. Maybe we have 1 until 2 maximum questions from the audience. Now we have a question from the audience in the chat. The first question is from Ms. Muhriani. Her question is about what method is most suitable for obtaining compounds that have high antioxidant.
We usually extract the plant with antioxidants with polar organic solvent. such because antioxidants usually have polyhydroxylated phenolic compound, which are polar. We know the scientific base which said polar dissolve polar. So we used aqueous solution or solvents such as methanol, ethanol to extract plants have such phytochemicals. For example, flavonoid can be extracted by 69% of ethanol. Tea are rich in tannin and polyphenols. It could be extracted by decoction, boiling the tea in hot water, and filtration. So the method using solvents such as aqueous or organic. This is the most suitable for getting compound with antioxidant activity.
Okay, thank you. And the last question from Miss Nadia. The question is about, she wants to ask about the use of essential oil or aromatherapy in daily. Based on your study, is there any recommendation of those of this use?
I recommend you to not use aromatherapy daily. You should have interval, 1 day interval. Use it one during a day and have another day interval. Totally 3 day in 3 day in the week. So if you use it as a massage, just a few drops from essential oil such as lavender, rosemary. If this is 3 days at week is enough. If you use it as inhalation, such as chamomile oil or mentha oil, for example, just 1 milli of the oil to a cup of tea, around a cup of water, around 50 milli, and inhale it, with blanket or piece of clothes. 1 milli of the oil and 15 milli of the water, hot water. Also 3 days in the week. No more that, because it has some small side effects such as dehydration.
That's all. Okay, thank you, Mr. Sabrisidan, from your answer. And from the committee, would like to give you a ceremonial giving certificate. Maybe you can end your slide, end your share screen, please. Okay. Okay, maybe you can see on your screen the certificate from the committee to Mr. Sabri A.H. Zidan as a speaker from Alauddin Medical and Health International Conference. Thank you very much to Mr. Sabri Zidan from your presentation, and hopefully we can meet again in another activity.
Yes, okay. This is valuable for me.
Thank you very much, and Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay, ladies and gentlemen, now we move to the third speaker from our symposium today. The third speaker will be delivered by Professor Lisa McKenna. Are you with us, Professor Lisa?
Selamat siang.
Selamat siang. Hi, how are you?
Yeah, baik.
Alhamdulillah. Okay, Miss Professor Lisa, we meet again
Yeah.
in another activity. We have met before in the Makassar, Indonesia, when you come to our university.
Yeah. It's a very beautiful place. I miss Makassar every day.
Okay. Now we would like to introduce your CV first before we move to your presentation. The third speaker will be delivered by Professor Lisa McKenna. Professor Lisa McKenna is Dean in the School of Nursing and Midwifery at Lathrop University in Melbourne, Australia since January 2017. She a registered nurse and registered midwife and holds postgraduate qualification in business administration, education history. Lisa is a fellow of Australian College of Nursing and a fellow of Australian and New Zealand College of Health Professional Education. She is recently appointed as a member of the Health Complaints Commissioner Advisory Council in the Victorian Department of Health, Australia. Lisa has extensive experience in teaching undergraduate and postgraduate health professionals, including nurses and midwives, and health professional education with a particular focus on workforce. Lisa regularly collaborates with Indonesian Nursing Faculty on research and publication. She recently led an Australian and Indonesian team on a funded project, comparative assessment of nursing standards in Indonesia and Australia. Lisa has published over 300 publications in the international referred journals, as well as 12 books, numerous book chapters, and national and international conference presentations. In July 2022, Lisa was inducted into Sigma International Researchers Hall of Fame. She has supervised 29 doctoral and 22 master and 9 honors research students to successful completion. From 2014 until 2022, Lisa was editor-in-chief in Collegian, the Australian Journal for Practice Scholarship and Research since 2014. She is an editorial advisor for Nurse Education Today, as well as for 2 Indonesian nursing journals, Indonesian Contemporary Nursing Journal and Jurnal Keperawatan Sudirman. From January 2024, Lisa will commence as editor-in-chief of the highly regarded international journal Clinical Stimulation in Nursing. Today, Professor Lisa McKenna will talk about technical development in nursing health service. Professor Lisa, time is yours.
Terima kasih, Pak. So thank you for inviting me to present at your seminar. I'm very pleased to be able to speak. And I was invited to talk about technological development in nursing and health sciences, which is something that I'm really passionate about, and I think is really important. We're seeing healthcare evolving very rapidly into technology. So I'm hoping that you'll enjoy my presentation and that you can learn something from my presentation. Okay. I thought before I start talking about the content, I would just show you where La Trobe is and where I'm from. So you're all very close to Australia, but I'm probably a long way away down in Melbourne. It's nearly 6 p.m. here in Melbourne. My university is based down in the state of Victoria, and we have 5 campuses in this state. The Melbourne campus is the city campus, and we have 4 regional campuses. We also have a small campus in Sydney, and it's a very big university and that specializes in health courses. And we'd love you to visit at any time. This is our main campus in Melbourne, and you can see the city in the background there. It's a very pretty campus, very, very big, very, very big. And we have kangaroos there sometimes. Oops. Okay. So I've been asked to talk about technology in health, and over recent decades, we've seen more and more and more technology, and we're starting to see it impact directly on the work of nurses and health professionals. And I'm going to talk through some of these things. So electronic health records are becoming more important, mobile devices, monitoring devices, and they might be wearable, but they also might be other types of monitoring. We're doing lots of e-learning, and I think with COVID, we learned to do lots more e-learning and e-communications. We're seeing mobile workstations. We see a lot of care being delivered electronically. So particularly during COVID, we had lots of telehealth, telenursing, telemedicine, doing a lot of our healthcare by remotely rather than face to face. And we're starting to see the growing use of artificial intelligence and robotics in healthcare. And so as we plan for the future, we're going to have to think about how these things will impact on our practice and the work of health professionals more broadly. In August 2017, the Council of Australian Governments approved a national digital health strategy for Australia. And this is really important background to why it's really important for us as health professionals to be part of of technology and to use technology in our care. As part of this, the government in Australia set up what they call My Health Record, and it's a virtual health record for every Australian who wanted it by the end of 2018. It created a centralised personal health record, and it enabled wherever you go to get health care or tests, it all gets put into a centralised medical record that can be accessed anywhere in Australia and by any health professional giving you health care. So for example, I can go to my GP and my visit goes on there. I can go and have x-rays or pathology that gets entered on there, and I have access to that as well as my health professional. It also contains all vaccination and other records, so it's become a very important part of the healthcare for Australians, and many countries around the world have started to do that. So we need to, as health professionals, understand how to access people's health records and how to utilise the data that's there, because it will keep a lifetime worth of data there. Within the hospital systems, we're seeing the emergence, and Australia's a little slow compared to some countries, of electronic medical records, or EMRs, also known as electronic health records, and these are being rolled out across Australian hospitals. So what these mean is that a patient's records are digitised. Everything that's done for patients is digitised, and you can see here in the picture, the nurse, I'm assuming it's a nurse, has a tablet where she would be putting vital signs data, so no more paper-based patient charts. Everything's being electronically uploaded into a mainframe. It has its benefits and it has its negative aspects as well, but the aim is to provide seamless care, enable quick access to documents, to results, to pathology, x-ray, all those sorts of things, and quick referrals from one practitioner to another. Many of these have built-in digital prescribing, and most of our public hospital prescribing now is done digitally, and our administration is done digitally as well. So I'll show you a little bit about that. Some of our hospitals are introducing advanced care planning and end-of-life care management, all by electronic medical record. So you can see that it's changing the way that health professionals practice, and the way the skills that they need are a little different. This is not unusual in Australian public hospitals now. So you would see a nurse walking around from bed to bed with what we call a cow, a computer on wheels. And my father recently was in palliative care, and all of his nursing staff came with one of these. So it's a computer. You can see there's drawers down in the bottom. I don't know if you can see my cursor. There's some drawers here where the patient's medications sit. The patient's ID tag is barcoded, so that medication administration is done with barcode scanning, and this is becoming the norm. So we're starting to see nurses with carrying the technology around. So everything is in this workstation. So again, it's changing the way that practice is happening, and potentially putting something in between the nurse and the patient, which is something we need to talk about a little later. So I did talk about telehealth before. So there's lots of terms used around. So telehealth, telenursing, telemedicine, depending on who's providing the care, is the provision of healthcare via telephone or video technology. We were doing a little bit of this before COVID, but during COVID became essential for the ongoing healthcare. And at one stage, my father was in a public hospital that wasn't allowing visitors, and the only way that we were able to access talking to him was via laptop. So there was lots of times we were using technology to support interactions for families, but also interactions with health professionals to reduce the spread of COVID. But now we're using this regardless of COVID. It's become part of the way that we're working, and there's a lot of telehealth. So I can make a choice to go to my GP in person, or I can meet my GP via telehealth now. What it does mean is that the clinicians who are using the technology need to have skills in the technology and to be able to adapt their practice to suit online delivery. For example, how do you do a physical health assessment via technology? There's lots of different ways you can do that, but you need to adapt your practice. And we're starting to see that's a skill we need to teach students in the classroom about giving care remotely. We're starting also to see lots of wearable monitoring devices, and this is going to continue to increase. I wear a watch that has lots of health reporting on it. It does my pulse oximetry, it does my heart rate, doesn't do my blood pressure yet, but in time these devices will do all of that. But we can monitor patients through different devices, and we're starting to see that happening. And this is some of the technology that's evolving for wearable. And so we're going to be able to monitor people at a distance as well through different devices. And watches are pretty common. Rings, there are certainly, we're starting to see lots of ring-based monitoring as well. So again, health professionals need to know how to use this data. They need to know how to access it. They need to know how to interpret it, and they need to know what to do about the data that's coming in. So again, technology is really going ahead in all sorts of ways. There's other things that are in place. So artificial intelligence, I'm not going to talk a lot about, but it is going to change healthcare dramatically, and how well we change with it will depend on how our curriculum incorporate these sorts of things. Artificial intelligence isn't new, but it does offer lots of new potential for healthcare and for quality healthcare outcomes. Machine learning uses algorithms to predict morbidity and mortality, so we can start to make predictions about outcomes for patients. It can also facilitate clinical decision making, and in some ways it already does. If my stress level gets too high on my watch, I get an alert. That's all algorithms putting that together. There might be alerts in our electronic medical records and in our mobile applications, and some of that's already there, and we don't even think of it as artificial intelligence, but it's already happening. What artificial intelligence does do, it enables us the ability to quickly consider large volumes of data and predict a person's risk of developing morbidity or mortality. It also allows us to increase the accuracy of our interventions, and it can flag patients at risk. So that's always a good thing. Automated adjustments in variable selection can help us to adjust care accordingly. And I've put a point down the bottom there about robots. We laugh about robots, but we know that there's nursing robots being used in Japan and Korea for all sorts of things. And in COVID, for example, robots were employed in some countries to reduce the use of PPE and patient contact, and the robots were doing the interacting with patients. Not in Australia, but in some countries, we started to see that. So those sorts of things will start to emerge, and we're going to have to work out how to work with that. Robots are not going to take nurses away. They might supplement the work of nurses, but not to take the care away. It's always going to be there, and a human element is always needed. But how we utilize artificial intelligence is the question, and I don't think we have the answer yet. One of the other things I think is really important here is that, and I'm talking about nursing and midwifery, and I appreciate there's other disciplines here, but using the technology, we have to implement strategies to ensure that our health professionals can use the technology. In Australia, we have already guiding documents and competencies for ICT, or information and communication technologies, for nursing and midwifery. For example, our Australian Nursing and Midwifery Federation, I think way back in 2015, developed national informatics standards for nurses and midwives. In 2020, the Australian government developed a capability framework for nurses and midwives around digital health, and a framework for implementing in curricula. So we're seeing lots of organisations developing standards and guidelines and competency standards so that nurses and midwives and other health professionals will have the skills to manage the technology and to be able to use it for their own benefit. So I think that's something to think about. For many years, we've had the disciplines of health informatics and nursing informatics. And they're specialist fields that focus on information technology to positively impact the patient and the health professional relationship through the effective collection, safeguarding, understanding, use of data to enhance health outcomes. Increasingly, we're seeing a lot of nurses and other health professionals specialising in information. And so it's not unusual now to see a nurse informatician in our hospitals, in our big public hospitals, and the nurse informatician's role is just on data. It's about computers, it's about use of technology, and it's about clinicians being able to access and utilize technology. So we're seeing a lot more of that specialty arising, and having doctors and nurses specialize in those fields will enable us to get the most out of technology as it continues to evolve. In Australia, we've got the Australian Health Informatics Competency Framework, and this is a whole framework to support the work of health informaticians, whether they be nurse informaticians, medical informaticians, or others, to actually do their work, and the standards they need to actually do their roles within healthcare. This was a second edition that came out in 2022. So we've had this framework for quite some time, and it is a role that's developed quite significantly. Digital literacy for nurses and other health professionals is therefore very important. It doesn't mean that everyone has to specialise in informatics, but every health professional is going to need fundamental skills to be able to use the technology, to use the data, big data, and analytical skills. And it's up to curriculum developers and educators to help build that into curricula, which means the academics themselves need to become clinically digitally literate and also able to understand what's happening in practice. So it requires new skills to function and use technologies to support healthcare. Different types of clinical skills, such as the ability to assess patients virtually and using remote devices. It does require foundational information and communication and technology skills, information and knowledge management, so knowing how to get data and what to do with it, understanding the professional and regulatory authority accountability around that, so the laws around privacy and information use, around legal and ethical frameworks, and how ICT can be used in actually delivering patient care. So I thought I'd share very quickly a study that was done by one of my PhD students. As part of her PhD, she did a number of studies around this area. And as one of her studies, she looked at nursing students' informatics competencies. And it was a relatively small study, but she used a survey to identify students' self-perceptions of their informatics competence and used a framework of nursing competencies from Canada. And she found, which was very surprising for us, that the average informatics competency was only at the level of somewhat competent, and only just over 40% felt competent. The highest level of competence was actually in using the technology, but students lacked comprehensive preparedness for competent technology integrated care. And I think one of the things that we concluded is that you can't assume that Generation Y and Z students actually have good technology skills. They might know how to use social media. We know they use lots of social media, but that doesn't necessarily translate into the ability to use information, to source information, and to apply it to care. So there was a real lag we found in the nursing curriculum, and we've actually gone through a process recently of rewriting our undergraduate nursing curriculum, and we've embedded digital health throughout every subject. And it does need to be made practical and embedded so that the students will come out with the technology skills they need at the end of their course. I want to finish by one important point. So one of the things that, I mean, technology is great. I love technology, but you can see that technology has the potential to change the way we practice. We have this potential to rely on the technology and not on our actual observational skills. And I do find where we use cardiac monitors, for example, students focus on the monitor, not on the patient. I think we need to really help students to understand it's not that technology is bad. It's there to support our work, but we need to use our fundamental skills in combination with the technology. And primarily, our professions are caring professions. They're connected with people, and it's really important that as technology in healthcare grows, that we don't lose the essence of healthcare, and that is about the hands-on care. It is about the caring for people, and it is about the empathy. And we need to find a way to balance all of this together to ensure that the essence of our professions are not lost, but we've got the benefit of healthcare to support our care. So in concluding, I'd like to say increasing use of technology is changing the way that nurses and other health professionals practice and learn. Technology should support but not replace quality care provision and clinical judgment and decision making. Nurses and health professionals need to be digitally literate and need to be involved in the development of technologies to support their care. And that's one point I didn't really make very strongly in the presentation, that if we're going to be using the technology, we need to be there in the developments of technology. So we need to teach our students about technology to be able to support its development. And ideally, they're driving the development. There's a need for curricula to be responsive to the changing care delivery context and the ongoing work around core competencies and capabilities with regards to technology, but that we don't lose the essence of nursing and health professional practice, that is caring and empathy amidst the growth in technology. Terima kasih, and I hope that that was informative for you.
Thank you very much, Professor Lisa, from your very nice presentation.
Thank you.
So you talk about the technology in the medical healthcare, and then you also talk about there is a several technologies such as telehealth, telenursing, telemedicine, and the last is AI. And there is a part that I think the most important thing from your presentation and is you said that technology is not bad, but is want to support us. I think that's the point. That is a really important point that maybe some people don't think that technology is also want to support us, not to make making crowded the situation.
It's very true, and I love technology. I love buying the new phone. I love buying the new tablets, the iPads. You know, I love that. But I think we need to be very careful about, you know, how we use technology to support care, that it is there to support us, not to take over care, and that, you know, nursing and other health professionals, it's still a human interaction, and we don't want to necessarily lose that.
Yes, of course. I think human interaction is very important to from the nurse to the patient and also from the medical team in the hospital. So Professor Lisa would like to read the question from the participant in the meeting chat.
Yeah, there's some long questions there.
Yeah, I think because your presentation is very nice and maybe some of them are really enthusiastic to ask. The first question from Miss Nurul Fadila. She said that she wants to ask about the implementation of telenursing in maternity patients, in which and how is regulation to improve health or digital literacy for improving health status generally. Could you share how the implementation in your country?
Sure. Well, I think we use a lot of electronic records in maternity. I think I'm talking to you as a midwife now, but I think that we have an over-reliance in maternity care on technology. We automatically assume that women are unwell. We put CTG monitors on. We use a lot of external monitoring, and midwives are grappling with that use of technology. In COVID, we did see some telehealth. There's a lot of developments happening in maternity care, but I think most of the technology that's been used in maternity is around monitoring baby, monitoring mother, but lots of devices. And so, again, I think midwives and nurses have the skills to do that without the technology. So we have to find a balance in using the technology when we need it, but not applying it for every woman, because we know how to monitor, we know how to listen to our baby's heart rates, we know how to do all that without the technology, but people have got used to using technology for everything. And so this is it's something that I find very challenging in maternity care, because we tend to over technologically do everything. That being said, we have a lot of women who don't want technology. They want everything to be very normal. And so the midwives are often trying to navigate between normal and abnormal. I'm probably waffling a lot, but it's a very difficult area, the use of technology in midwifery, because we tend to use it too much instead of going back to our fundamental skills. I might stop that question there.
Professor Lisa, we have a long question from Mr. JC from Gambia, but I will conclude maybe to make it easy. So he is JC from Gambia. He want to ask about optimal integration of technology in nursing. So maybe you can explain how can Australian healthcare system strike a balance between adopting the technology and nursing environment in the healthcare.
I think
Maybe
that's
the question.
it's a fantastic question, and I could talk for an hour, I think, on this one. So if I were to show you the map of Australia again, I would show you that only along the east coast is most of the population. The rest of the country is Guru desert, yeah? And so people work very remotely in small communities, and there's often no doctors, there's only nurses, and they do a lot of telehealth. So nurses are doing lots of telenursing with doctors in the cities, in the regional cities, for example. Australia has a big issue with equity of healthcare anyway. If you live in one of the big cities, you can get good at healthcare, but if you live anywhere else, it's very hard to find healthcare. It's very hard to get healthcare. But most of the rural communities, those little communities, have nurses that work remotely. They do everything, those nurses. And so they will often use telehealth to communicate with the health professionals that they need that aren't in the rural areas. But it is a huge issue for us, like it is for you in some of your remote islands where you don't have the health care. We struggle also with a lot of care to our remote and regional areas. And there is yes, as I said, if you live in the city, you can access good healthcare, but if you don't, it gets harder to get access. So nurses have to use technology more and more in those remote areas. And we have some amazing remote area nurses who work out in the deserts with small communities of Indigenous people who already have much worse healthcare outcomes than our non-Indigenous peoples. So we have a lot of health inequities in Australia that people are trying to manage all the time. Yeah, it's and technology continues to be the savior of that as we work. So yeah.
Okay, maybe we have the last question from for Professor Lisa, because maybe still there is several questions, but this is maybe the last. This question is about in the midwifery major, when the students can learn the technology from your vision or from your curriculum over there.
It's included right throughout all of the curriculum. So we have digital health included across all of our curriculum, not in a particular subject. It's there all the time. And it's increasingly important that we do that. And someone, Ilmi, is Ilmi here? Ilmi asked, Ilmi is here. She's asked about telehealth for older people, and there are certainly there's a lot more. We're seeing a lot more telehealth in aged care facilities in Australia, especially with COVID. We saw a lot of lockdowns because of COVID in our aged care facilities. So telehealth was used very often, and and people are becoming used to it. So in COVID they had to learn how to use it. Now they're starting to use it more, and that's really important in aged care because there's not medical support there all the time. So if you need to get medical support, you can do it much more easily through telehealth. So yeah, it's definitely there. I think I've answered your question, Ilmi.
Okay, Professor Lisa, there is one person that want to talk interactive to you. Is it possible for you?
Yeah.
Okay, I think Mr. Muhammad Fawzul Azim, would you want to talk with Professor Lisa? Maybe you have a question. Sorry, you are unmute, and then I will ask to unmute. Maybe you can use your microphone right now.
All right, thank you so much, Mr. Ahmad, for the opportunity given to me. Nice to meet you, Professor Lisa.
You too.
Your Indonesian vocabulary is good.
Sedikit saja.
So you already visit in Indonesia?
Banyak, banyak.
How many times?
Yeah, yeah. Even Makassar many times.
All
Yeah,
right.
Makassar is my second home.
Wow. All right.
Thank you.
All right, Professor Lisa, very happy to be able to listen to your presentation. I'm Fauzul from Hasanuddin University. I'm a bachelor student. If you ever heard about my university, studying
Well, I
in
spent I spent 4 weeks there last year.
All right.
Yeah, but I missed you.
Yeah, Professor. Yeah. So I got a lot of new knowledge from your very insightful and wonderful presentation. I have always been interested in Australia because one of my goals is to continue my master studies there, specifically in your region, in Melbourne, the University of Melbourne, and I want to take a major uh, environmental health or something like that because I interested with that major. So one of the reason is because I always hear that access and health service in Australia is very high. Is right? Yeah. So some of the technologies you mentioned before are very interesting and are certainly an evaluation for our country, Indonesia, and we hope that Indonesia can also create and adapt technology like that too. So from some of the technologies above, before I noticed about robots, I'm just curious, how difficult is it to produce a robot and how much money is budgeted to produce the robot and how big is the influence of assistant from AI, and will the role of the humans be replaced by the presence of these robots?
Thank you for that question. That's really good. And I'm fascinated with the idea of robots to help nurses, but certainly it's Japan and South Korea where those developments are happening. I'm sure it's very expensive. We don't have any in Australia that I know of, but I know that as time goes, that they might get cheaper, and we might see them doing some things, but they won't take over nursing. Nursing's human, it's caring, and they might do things for us. So we can get them to deliver things, we can use them for certain things, but I don't ever see robots replacing nurses. Somehow, sometime in the future, we might have them as a supportive care technology to help us with our work. I think we still don't know yet. It's still very early days, but there's some really interesting things I've been able to Google about robots and robo nurses and all sorts of things. So I know in Japan, they're doing lots of work on these sorts of things, which they love to do in Japan. Australia's not really up to that, but I think we do need to think about how we might use robots to help us. We know in operating theatres, surgeons are using a lot of robotics to do some of their procedures now. They're not taking over the surgeon's work, but they're making it more precise. So I don't have the answer for now, but it's exciting, and we need to think about how we might use it to help our work, but not to take it over. Yeah. Fantastic. Thank you.
Thank you, Professor Lisa, from your explanation. Maybe from the community would like to see you the certificate. Maybe I will share the screen. So maybe you can see in your screen right now. So this is the certificate.
Yeah, terima kasih banyak.
You're welcome. So we will send the certificate to you through email.
Lovely. Thank you. And thank you again for inviting me to present. I hope to see you in person again soon.
Thank you very much. Thank you very much for Professor Lisa for your time, and have a nice day.
You too. Thank you.
Okay, ladies and gentlemen, that is the third speaker from Professor Lisa, and now we will move to the the last speaker. This is from Dr. Waode Nova Noviayanti Rahman. Are you with us? Ibu Dr. Waode Nova, are you with us? Maybe you can unmute. I can hear your voice. Maybe you can talk, please. Miss Waode.
Yeah, hello. Assalamualaikum.
Waalaikumsalam. Hi.
Hi.
Okay, because you are in the room, before you start your presentation, I will read your CV. Okay, ladies and gentlemen, now the speakers is Dr. Waode Nova Novianti Rahman, SPSI MCAS. She is a lecturer from Faculty of Health of University Mandala Waluya from Kendari, Sulawesi Tenggara. She is also finished her psychological and magister in health and doctoral in 2022. She will talk about emotional management of adolescents to prevent bullying. Okay, Ibu Waode Nova Rahman, are you ready?
Yeah, okay.
Okay, time is yours. Maybe you can share your screen. Do you want to share your screen by yourself?
Yeah, okay, cool. Mm, okay. Okay, my presence about the emotional management of adolescent resilience to prevent bullying. Okay, the introduction. Bullying is a situation in which an individual or group abuses power. Bullying behavior can be interpreted as hurting both physically and mentally, which is done by a person or group of people to other people repeatedly. In Indonesia, the incidence of bullying has increased by 70% since 2013 until 2019. Highly aggressive behavior, such as bullying in the school environment, is 84%. Junior Chamber International, or GCI, noted that around 40% of students are victims of bullying in several cities. In Bogor City, West Java, 30 until 40 of victims of bullying are still in elementary school, junior high school, and senior high school. Bullying behavior often occurs when someone has physical or psychological deficient. The latest data from the Indonesian Child Protection Commission or ACPC for 2002 reported 226 cases of bullying with physical and mental violence occurring in the school environment, including 18 of bullying in cyberspace. The purpose of the study aims to explore emotional management skills for adolescent resilience to prevent bullying behavior. The research method type of research is an analytic research with a cross-sectional design. And the result, the study showed 4.21% or 31% students were in the very low category, and 4.1% or 145 students were in the low category. The fact indicates the phenomenon of bullying in Indonesia is not a new case in school and residential environments. According to Ken Rigby, bullying is a desire to harm, causing an individual or a group to suffer. This action is carried out directly by an individual or a stronger group, usually occurring repeatedly, and the perpetrator engages in bullying with a sense of enjoyment. The conclusion of the study, the skill level of junior high school student emotional management skill in the low category, which meant that many students have the potential to have a high tendency to bully. Emotional intelligence can be acquired through extensive learning from personal experience. Emotional intelligence is a fundamental skill or ability that profoundly influences all other abilities, either facilitating or hindering them. Someone who is said to process emotional intelligence met the following five criteria. 1. Able to recognize their own emotion. 2. Able of controlling emotion according to the situation or condition. 3. Able to emotion to enhance motivation. 4. Able of recognizing the emotion of others. 5. Able of interacting positively with others. Okay, thank you for my presentation. I give to the moderator.
Okay, thank you very much. The presentation from Ibu Alauddin Farahman. She talked about bullying. So maybe there is a question from the audience in the Zoom. Maybe you can write in the meeting chat, or maybe you can raise your hand to ask directly to the Ibu Alauddin. Ibu Alauddin, maybe you can end your share screen, please. Maybe you can end your share screen, bisa dihentikan share screen-nya. Okay, thank you. So Ibu Alauddin, about bullying, this is happen also not only in the child environment, also it happen in the university, sometimes in the student in university. Maybe until we wait from the audience, I would like to ask about what is your opinion about bullying in the student in the university? Why it can be happen and what is the solution?
Can you give solution to yang Anda memberikan?
Jadi pertanyaannya Bu Ode mungkin tentang bagaimana menghadapi situasi bullying bukan hanya pada anak-anak tapi di tingkat universitas juga bahkan ada fenomena seperti ini. Menurut Ibu Ode bagaimana solusinya? Okay, now you can unmute. Bu Ode, could you hear my voice? Your mic is off.
Oh yeah, sorry. Okay,
Yes.
how to stopping bullying and emotional management. Sorry, how to design stopping bullying by emotional management. Okay. Sorry.
Ibu Ode, we cannot see you and we can hear your voice. Ibu Ode, maybe you can unmute. Your speaker is off. We cannot hear your voice. Not yet, please. Unmute, please. Unmute. Ya, oke.
Oh ya, oke. Baik, saya akan mencoba menjawab bagaimana menghentikan bullying. Jadi bullying itu bisa dihentikan dengan mengelola emosi. Mengelola emosi itu hal-hal yang pertama kita lakukan adalah kita harus bisa mampu atau mengenali dulu diri sendiri, kemudian memahami apa yang menjadi atau menciptakan kondisi yang dapat membuat kita nyaman pada situasi tersebut, melakukan hal-hal yang kita senangi, misalnya berolahraga, atau melakukan hal-hal yang bisa membuat situasi psikologis kita nyaman dengan banyak sesuatu yang bisa membuat kita nyaman. Kemudian kalau menghentikan perilaku bullying di sekolah itu sendiri atau di lingkungan pekerjaan, biasanya anak-anak sekolah atau pelajar diaktifkan atau disibukkan dengan kegiatan-kegiatan ekstrakurikuler, misalnya dengan kegiatan olahraga, kemudian kursus-kursus yang bisa mereka sukai, misalnya melakukan hal-hal yang mereka senangi, menciptakan lingkungan pertemanan atau membangun circle yang positif. Saya kira seperti itu yang bisa dilakukan untuk mencegah bullying atau menghentikan bullying di lingkungan sekolah maupun tempat kerja.
Okay, thank you Ibu Awode. I will translate into English because we have a participant from outside of Indonesia. So Ibu Awode asked about the prevention about bullying. So he said that if we want to prevent the bullying, we have to make a comfort situation or a comfort environment that can make us feel comfort itself. And then we can make several activities that can make the student will be busy with that activity, and then they can make a good situation with their friends. And also we can add several activities such as exercise, sport, or several course that can make the student will be feel enjoy and feel free to talk each other. And that is the point, that how to prevent the bullying itself in the student. Okay, Ibu Ode, I think because we are limited by the time, so this is the end of the session today. And before we close our symposium, I would like to show you the certificate of speaker from the committee. So, Ibu Dr. Waode, can you see your certificate in the screen? Maybe you can on your camera, please. And maybe you can unmute your mic. Okay, Ibu Waode, this is your certificate from the committee. Thank you very much for your presentation.
Thank you very much.
Okay, Ibu Waode, we will send this certificate to you through email.
Okay, thank you.
Okay, thank you very much from Ibu Waode. Maybe you can give a big applause for all of the participants and all of the speakers today. So before I close this symposium, to all of the audience, tomorrow we still have the third symposium. It will be delivered by several gorgeous speakers from University Islamic Alauddin University. We have a professor and we have a postdoctoral from UIN. And also tomorrow we have oral presentation to all of the participants that have registered as the oral presenter. So, ladies and gentlemen, thank you very much for your participation. I'm Ahmad Jamaluddin. Assalamualaikum warahmatullahi wabarakatuh. I give it back to the master of ceremony.
Okay, thank you very much to Mr. Ahmad Jamaluddin. Ahmad J, sorry. I'm sorry. For very interesting symposium, second symposium of our international conference today, Alauddin Health and Medical International Conference. Thank you very much to lead this session very well. And also we gonna say thank you for all speakers. Erman Gedikli, PhD from Turkey, Sabri Ahazidan from Al-Azhar University, Cairo, Professor Lisa McFennell from Melbourne, Australia, and also Dr. Waode Nova Noviati Rahman from Mandala Waluya University. All participants, speakers, and moderators, this session is come to the end for the symposium of the second Alauddin Health and Medical International Conference today. And also we're gonna continue this session tomorrow by hybrid, yes. So don't forget to join with us tomorrow morning. Thank you very much. Have a nice day. Wassalamualaikum warahmatullahi wabarakatuh.